Dear colleagues, welcome to the second annual OncoAlert Colloquium brought to you by the OncoAlert Network and our amazing partners at ESO, the European School of Oncology, eCancer, EONS, the European Oncology Nursing Society, MASC, the Association of Supportive Care, CIOG, the Society for Geriatric Oncology, IGCS, the International Gynecologic Cancer Society, and SWOG Cancer Research Network. My name is Gilbert Morgan. I'm a clinical oncologist, displaced Texan practicing in southern Sweden, and director of the OncoAlert Network. The colloquium, which you're about to see, is an end-of-the-year review taking place daily from January 10 to January 16, bringing you the most impacting findings in oncology of 2021, divided by tumor type, and delivered by an amazing hand-picked faculty of world-renowned oncologists, oncology nurses, and of course, amazing patient advocates. This, as with every OncoAlert initiative, has been realized with absolutely no financial support. All the presentations, what you are about to see this week, will be free, always available, and will require no registration, and we will not be tracking your data. The amazing faculty that makes up our network believes that through working together and making education available to all is the only way to move forward for the development of our field and for the better treatment of our patients. We welcome you to day 3 of the colloquium, where we'll be seeing presentations on breast cancer 2021. Our presenters are Dr. Erika Hamilton, Director of Breast and Gyn Cancer Research at Sarah Cannon, USA, presenting on advanced hormone receptor positive, HER2 positive breast cancer. Dr. Bhawna Sirohi, Lead Medical Oncologist at Polo Proton Cancer Center in India, presenting on early hormone receptor positive, HER2 positive breast cancer. Ms. Ginny Mason RN, Director of IBC Research Foundation USA, giving us the patient advocate perspective. Dr. Hope Rugo, Director of Breast Cancer and Clinical Trials Education at UCSF USA, presenting on advanced triple-negative breast cancer. Dr. Sara Tolaney, Chief Division of Breast Oncology at Dana Farber USA, presenting on early triple-negative breast cancer. Dr. Matteo Lambertini, Medical Oncology Consultant at the University of Genova, Italy, presenting on fertility presentation and breast cancer. And ending up with Dr. Icro Meattini, Radiation Oncologist at the University of Florence, Italy, presenting on the year in review in breast cancer radiation therapy. On behalf of OncoAlert and our partners and our faculty, it is an immense honor to be able to present this colloquium for you, our colleague. So without further ado, day 3 of the OncoAlert colloquium, and to get us started, Dr. Erika Hamilton.
Good morning. I'm Dr. Erika Hamilton, and I lead the breast cancer research program here at Sarah Cannon Research Institute, Tennessee Oncology in Nashville, Tennessee. I'm happy to join OncoAlert and go over some breast cancer updates. My topic is advances in metastatic breast cancer, and I'm going to cover both HER2 positive and hormone receptor positive. So essentially, all of metastatic breast cancer minus the triple negative. I apologize for my voice in advance. I have a little bit of laryngitis, so hopefully I don't start coughing on you. So first agenda is HER2 positive, then we're going to go over hormone receptor positive, and a little bit of a twist on some ADCs we see coming in this space as well. So first for HER2 positive, the management of HER2 positive metastatic disease in early 2021, our regimen was really taxane in combination with Herceptin and Perjeta in the first line as THP. In the second line was TDM1, and in the third line, it was a little bit up for grabs before. It was capecitabine in combination with lapatinib, trastuzumab, chemotherapy with trastuzumab, and then we had the approval of 2 new agents, tucatinib in combination of capecitabine with trastuzumab, and then also trastuzumab deruxtecan. And so those really were third-line trials, third line after THP and after TDM1, although tucatinib did have a second-line approval within the FDA approval in the United States. And so we're going to talk about some of the new data and then maybe how this algorithm has really changed now. So trastuzumab deruxtecan, I'm sure you're all quite familiar with this drug, also known as Enhertu or TDXD if we're trying to save some syllables. This is an antibody drug conjugate with a high potency of payload. The DAR or drug to antibody ratio is about 8. very stable linker payload, and the payload is a topoisomerase 1 inhibitor. And so this DXD payload is going to be quite common with some of the new antibody drug conjugates coming. So the rationale for DESTINY-Breast03, really you can see the PFS of about 18 months with Cleopatra, taxane, pertuzumab, trastuzumab on the left. When the Amelia trial with TDM1, our PFS was about 9.6 months. And then in DESTINY-Breast01, which was a very heavily pretreated population, a median of 6 priors in the phase 1 study, the PFS was 19.4 months. So this really kind of raised the question of, is this really outperforming our standard HER2 agents, and should we be moving this up into the earlier setting? And so TDXD was evaluated in a head-to-head trial in the second-line setting against TDM1 for our patients with metastatic disease that is HER2 expressing in DESTINY-Breast03. This was the trial design, very simple, a randomization of 1-to-1 TDM1 versus TDXD. And this is kind of how it broke out. The majority of our patients did have visceral disease, which would have been expected with our HER2 positive patients at about 70%. Really about 20% of patients on study had stable brain metastases. Unstable or progressing or untreated brain metastases were not allowed in DESTINY-Breast03. And you can see the breakout of prior lines, really universal. Everyone had seen trastuzumab, about 60% had seen pertuzumab, and about 15% had seen another TKI. And so this is what we saw in independent review was 6.8 months PFS of TDM1 and not reached with TDXD with a hazard ratio of 0.28. So clearly here, a large magnitude of benefit. And if we look at the progression-free survival as seen by investigator, this was 7.2 months versus 25.1 months. So a change or an improvement of almost a year and a half. I also think that this is important really to just set the stage, that TDM1 is performing at about 6.8 months post pertuzumab. Obviously, a PFS now of 2 years with TDXD is quite meaningful for our patients. What did we see if we looked at those that had brain metastases? Did these patients not perform as well? That was not the case. The hazard ratio was 0.25. Progression-free survival with TDM1 was about 3 months, and with TDXD was 15 months. If you look at the 12-month progression-free rate, it was only about 20% of patients were receiving TDM1 and was over 70% if they were receiving TDXD. We also saw the intracranial response rates in patients with brain metastases. We saw intracranial responses of over 60% with TDXD. Sorry, I told you this was going to happen. So the treatment emergent adverse events, we certainly see GI toxicity. This was more common with TDXD than it was with TDM1. We obviously see thrombocytopenia that was actually more common with TDM1 than TDXD. And we also see alopecia. Our antibody drug conjugates across the board do not all universally cause alopecia, but TDXD does. One thing that we were very carefully following was interstitial lung disease or pneumonitis. We saw no grade 4 or 5 events with TDXD, and this was different than what we saw in DESTINY-Breast01. We were very closely following this as we saw fatal cases of pneumonitis with increased monitoring and guidelines of even holding drug with grade 1 ILD. We've been able to eliminate these grade 4 and grade 5 event, and we saw less than 1% grade 3. So I think this was very reassuring to us that not only TDXD performs very well in the earlier setting, it's also safe to give in the earlier settings. And so in summary, highly statistically significant and clinically meaningful improvement of PFS, about an 18-month increase. This was across subgroups, whether patients had brain metastases that were stable or did not have brain metastases. Our overall survival data is immature, but we're eagerly watching this. And then obviously less ILD, no fatal cases, and less than 1% grade 3 cases. So we do anticipate seeing FDA approval in the second line setting for TDXD. Another trial that we have recently heard more about was the TULIP trial. This was a phase 3 trial of SYD 985. And this is also an antibody drug conjugate based on trastuzumab and a cleavable linker of duocarmycin. The drug to antibody ratio ranges in about the 2 to 3 range here. It's an alkylator. In this trial, patients have had at least 2 therapies, and they were randomized to SYD 985 or treatment of physician's choice. And you can see the options down there, 4 options. 3 chemotherapies in combination with trastuzumab and 1 capecitabine lapatinib. And what did we see? Treatment of physician's choice was a progression-free survival of 4.9 months, and SYD 985 was a progression-free survival of 7 months for a significant hazard ratio of 0.64 improvement. Overall survival was not statistically significant yet, 16 months versus 20 months with SYD 985 hazard ratio is 0.83 with a p-value of 0.15. So in summary, we did see an improvement of progression-free survival. We did not see overall survival benefit at this time. Unfortunately, we also saw quite common ocular toxicity with this drug, over 75% of patients treated with SYD 985. We also saw grade 3 pneumonitis, which we're becoming more familiar with the ADCs in about 2.4% of patients. So given the results now with Destiny Breast 03 and the frequency of ocular toxicity with SYD 985, the role and how this will settle out is not quite clear at this time. Another antibody drug conjugate that I just want to briefly mention is ARX 788. Again, it's a HER2 targeting antibody drug conjugate with AS269 payload. It has a non-cleavable linker. It's a tubulin inhibitor, and it binds with a different binding site on tubulin than DM1 does. There was a phase 1 trial, ACE Breast 01, in HER2 positive metastatic disease with a median of 6 priors. And the overall response data from 29 patients treated at 1.5 mg per kg every 3 weeks here is shown. And so you can see the overall response for a different proportion here. Disease control rate was 100%, and the median progression-free survival was 17 months. ACE Breast 03 is now a phase 2 trial of AR788 in HER2 positive metastatic disease that have already been treated with TDM1, TDXD, tucatinib. So we eagerly await the findings of this. We also saw some data from ASCO this previous year in 2021 from HER2CLIMB. As you recall, HER2CLIMB was the registrational trial that got approval for tucatinib in combination with capecitabine and trastuzumab. And they met all of their primary endpoints: progression-free survival, overall survival, as well as progression-free survival in patients that had brain mets. Also recall that this trial was unique, as it not only allowed patients with stable brain metastases, but also allowed patients that had untreated brain metastases or treated and subsequently progressive. We saw the updated overall survival now with a median follow-up of almost 30 months. And here we see a hazard ratio of 0.73, 19.2 months with capecitabine trastuzumab, and 24.7 months when tucatinib was added. So where are things going to settle out? Obviously, HER2 is a crowded space, and this is a great thing for us and a great thing for our patients, as we are certainly having our hands on more agents that are effective. So in the first line, we're still seeing THP used. In the second line, we now have Destiny Breast 03 results showing a clear head-to-head comparison against TDM1 that TDXD and HER2 is beating this by almost 1.5 years progression-free survival. So I do see trastuzumab deruxtecan moving up into the second line here. And in the third line, we have a variety of options. I think we will see capecitabine, trastuzumab, and tucatinib used quite frequently. We still have other regimens. In the United States, we also have margetuximab approved. However, the magnitude of benefit here really is much smaller. Certainly with tucatinib having an overall survival advantage, I anticipate seeing this combination used quite frequently. So what's coming? So we have a handful of Destiny breast studies, 07, 09, and 12. 07 is first line TDXD combinations, a very interesting trial where TDXD may even be combined with endocrine agents if patients are hormone receptor positive, or targeted agents if they are not, et cetera. So multiple arms on that trial and really looking in the first line. Destiny Breast 09 is a head-to-head comparison of THP, our standard first line regimen, versus TDXD. Destiny Breast 12 is TDXD for patients with or without brain metastases in the second to third line space. So really getting a more rigorous look at those patients with brain metastases. We also have HER2 05. I'm very excited for this trial. This is after patients kind of receive their taxane, Herceptin, Perjeta, and then go into the maintenance phase. This may be where we're just continuing HP, or we may be doing HP with endocrine therapy if patients are ER positive. But here we also have the opportunity to add tucatinib. So really adding tucatinib to that HP is maintenance in the first line setting. And then we also have HER2 04, which is TDXD plus tucatinib. So getting both of our new agents and able to give those simultaneously. So let's move on a bit to hormone receptor positive and HER2 negative metastatic disease. So this is Mona Lisa 2, an oldie but goodie. We're well familiar with this trial. These patients were postmenopausal women with hormone receptor positive disease that had not received any therapy in the advanced setting. They were allowed to have prior neoadjuvant or adjuvant endocrine therapy, including tamoxifen. Almost 700 patients were enrolled in this trial, and patients received either letrozole alone or letrozole in combination with ribociclib. And so what we saw was updated overall survival. Now at a median follow-up of 80 months, we see 51.4 months with endocrine therapy alone and 63.9 months when CDK4/6 of ribociclib is added to endocrine therapy. So this is an improvement now in overall survival of more than a year. I think the other milestone that we were very encouraged to see is that our patients with hormone receptor positive untreated disease, their median survival is now crossing 5 years. So it certainly goes to show the improvement in this space, and we're not done improving. We're certainly aiming for higher as well. So what about if we look across subgroups, whether patients had bone metastases on the top or liver metastases on the bottom of this slide? Patients with bone metastases still here a clear benefit, hazard ratio of 0.78. And if they did not have bone metastases, a hazard ratio of 0.77. Down at the bottom with liver metastases, so kind of what we would consider more aggressive visceral disease, again, hazard ratio of 0.81 with liver metastases, 0.77 without. So really kind of regardless of where our patients have a disease, we would anticipate all patients to benefit from the addition of ribociclib and a CDK4/6 inhibitor. And we already talked about this improvement in long-term survival. So we also saw a pooled analysis at San Antonio Breast this past month in December for Mona Lisa 2, 3, and 7 trials. So really the endocrine agents with ribociclib across the board. And we saw obviously in these trials a statistically significant both progression-free survival and overall survival benefit in these phase 3 trials. And so we looked at the pooled Mona Lisa data set and intrinsic subtype. And you can see on the right in this pie graph how this broke down. The majority of patients were luminal A, about a quarter of patients were luminal B. We had about 15% that were HER2 enriched, and then about 3% in basal-like. And so what we saw was that the intrinsic subtype was prognostic for overall survival. We saw benefit for ribociclib in combination with endocrine therapy across the board, luminal A, luminal B, HER2 enriched, but not for those that were basal-like. And so this just goes to outline this. Again, hazard ratio of 0.75 for luminal A, 0.69 for luminal B, even HER2 enriched 0.60, but not a benefit for those patients that had basal-like tumors on intrinsic subtyping. So my question really here is that when we break this down, it's about 30 patients. And so, the majority of these tumor samples, about 71%, were actually from primary tumors. And so I'm wondering whether some of these patients had actually become triple negative, or whether these were patients that had a basal intrinsic type, but still expressed estrogen receptor. So that certainly would be very interesting to know. So let's move on to the SERDs. A lot of talk about SERDs over the past several years, and we've recently now had presentation by Dr. Bardia of the first randomized SERD data. So really, what is a SERD? The aromatase inhibitors, as we all know, really work in patients that are menopausal or pharmacologically postmenopausal. And work by inhibiting conversion of normal circulating body steroids into estrogen via the enzyme aromatase. The SERMs, or tamoxifen, terimifene, there's also an investigational SERM, work a little bit differently by being an agonist and both an antagonist depending on the target tissue. And the SERDs not only bind the estrogen receptor, but instead of just causing a conformational change, they also lead to estrogen receptor degraders. So it degrades that receptor. I kind of tell my patients that it chews it up and it spits it out. And so there's a variety of compounds in this space. Some of them are listed here: amcinestrant, camizestrant, elacestrant, giredestrant, imlunestrant, and rinidestrant, a mouthful. There's certainly more as well. By my count, there's a double-digit SERDs in development. So the advantages of these is oral formulation. It is no longer a shot in the hip for fulvestrant, et cetera. Higher potency, activity in patients that have ESR1 mutations. We would anticipate that we may be seeing a higher percentage of our patients in coming years with ESR1 mutations as patients are on aromatase inhibitors longer in combination with CDK4/6 inhibitors. And certainly they have activity in the post-endocrine therapy CDK4/6 setting. So this is just showing a snapshot from the phase 1 trials with a handful of agents: amcinestrant up here on the top left, elacestrant on the top right, giredestrant on the bottom left, and imlunestrant on the bottom right. And so really these are just swimmer plots of 4 different oral SERDs. The dotted lines you see in some of these are the 6-month points, just to kind of standardize these. And so, these are phase 1 patients that are heavily pretreated. You can kind of see on the left, and you're probably going to have to pause this slide and zoom in, but many of these patients had already seen prior CDK4/6, even prior SERD, and are really a handful of patients getting benefit beyond 6 months, when really we know that even fulvestrant is not performing beyond 2 months in a post-CDK4/6. So to be seeing this type of results in patients that have even seen fulvestrant is quite encouraging for us. So this was the Emerald trial. Dr. Bardia presented this for us at San Antonio in December of 2021. These patients were men and postmenopausal women, and they had progressed or relapsed on or after 1 or 2 lines of endocrine therapy for advanced disease, and they had to have received a CDK4/6 inhibitor. They could have had up to 1 line of chemotherapy for advanced disease. So a very real world, these are the patients that we're seeing in our clinic population. Almost 500 patients were randomized either to an investigator's choice of fulvestrant, anastrozole, letrozole, or exemestane, or they were randomized to elacestrant. And so what did we see as far as the patients that came on to this study? Visceral metastases were about 70%. The number of prior lines of chemotherapy, about 3/4 of patients had not seen chemotherapy, and about 20 to 25% had. As far as bone-only disease, this was relatively infrequent in the 10 to 15% range. And so the co-primary endpoints on the top left, we see progression-free survival. This was statistically significant with a hazard ratio of 0.69 and a p-value of 0.0018. The benefit was 1.91 months of treatment of physician's choice standard of care versus 2.79 months with elacestrant. And if we look at those patients that did have an ESR1 mutation, we do see the magnitude of benefit increasing some, 1.87 months up to 3.78 months. So the summary, this was statistically significant, although it was modest improvement, really a bit smaller than I think many of us would have liked to see. Higher progression-free survival rate at 6 and 12 months with elacestrant versus standard of care endocrine therapy. What stood out to me looking at these curves is about 50% of our patients progressed immediately off the first scan, really suggesting that these patients weren't sensitive to endocrine therapy, and probably this wasn't the best treatment option for them. However, still being ER positive, we don't have a whole lot of options of how to figure out who these patients are post-endocrine therapy and CDK4/6 that are no longer sensitive to endocrine therapies and need to move on to other types of drugs versus who will. But if we take a look at the patients that at least made it through that first scan, being on elacestrant, certainly a higher chance that they're going to be on drug at 6 months, at 12 months, et cetera. Nausea was the most common toxicity. Elacestrant certainly could be the first oral SERD to enter the clinic. And there are trials evaluating other oral SERDs in combination with CDK4/6 inhibitors, et cetera, and a handful are ongoing. So I also wanted to briefly talk about another class of molecules a little bit similar to the SERDs, but a bit different. So this is the PROTAC. So this is a proteolysis targeting chimera. You can see the little rainbow molecule here on the left goes and binds the target protein. Here, the target protein for us is the estrogen receptor itself. When that is bound, it recruits the E3 ligase. And when E3 ligase comes and binds the estrogen receptor, it leads to ubiquination of the receptor. This flags it to the cell for degradation, and the proteasome comes in and chomps up the estrogen receptor and degrades it. So it's a degrader like a SERD, but it's a different flavor. It works in a different way. And so from the phase 1 monotherapy study of ARV-471, the median of 4 prior lines of therapy in any setting, 100% of patients had been treated with CDK4/6 inhibitors. This is a little bit different than the other phase 1 data we've seen with some of the traditional SERDs, where how many patients had seen CDK4/6 inhibitors were in flux. 83% had been treated with SERD, 80% fulvestrant, and 10% with an investigational SERD, and 78%. So most patients had seen chemotherapy. And this is what we saw. You can see different dose levels on the right by color, really looking like there's activity across multiple dose levels here. There were no DLTs, no grade 4 toxicities. The MTD was not reached, well-tolerated drug. Most treatment-related adverse events were grade 1 or grade 2. We certainly saw responses in patients that had had prior CDK4/6. All of them had. We certainly saw responses for prior fulvestrant, and even great responses in patients that had already seen an investigational SERD, which is this 4th row on the graph on your left where the dots are. The clinical benefit rate was 40%, and 3 patients had a confirmed partial response. 14 patients are still ongoing at the time of study cutoff. So what are we seeing across the oral SERDs? I have this table put up here, certainly a number of drugs on this. I've included CDK4/6 treated in that second column, ranging kind of from 50% with LSZ-102 all the way up to 100% with ARV-471. The number that had already seen fulvestrant, which really varies from study to study, as low as 20%, as high as 80%. The overall response rate, which I would argue is universally low, and probably not our most meaningful outcome for ER-positive disease. Our most meaningful outcome really is that clinical benefit rate or progression-free survival. And then I've also included median progression-free survival and whether we have activity in ESR1 mutant population. So certainly quite encouraging. Here is some select data with SERD plus CDK4/6 inhibitor. And so you can see the agents here on the left, the prior therapies with CDK4/6 for fulvestrant, and the efficacy and response evaluable patients. So certainly our clinical benefit rate is higher, our response rate is higher as these patients have not seen CDK4/6. So certainly intrigued to see the SERD data in combination with CDK4/6 inhibitors. So what clinical trials do we have coming with select SERDs? We have a handful. I'll orient you to this graph. On the top, we have the different SERDs along the top of the X axis here. On the Y-axis, the combination with CDK4/6. You can see Persevera, AMEERA-5, SERENA-4, EMBER-1. In a post-CDK4/6 setting, also have a handful of drugs across all of these compounds in the settings, and then also other combinations, brain metastases in combination with CDK7s, in combination with mTOR, with everolimus, et cetera. So we're certainly going to be getting more data from our SERDs, not just a single agent, but also in combination with CDK4/6, post-CDK4/6 in larger trials, and in novel combinations. So what are the side effects that we're seeing with oral SERDs? We certainly can see GI toxicity. We can see this across most compounds, but to a varying degree. It doesn't seem that they're all created equal here. This can include nausea and vomiting, or it can include diarrhea. Some of our agents, we can also see some cardiac effects. This tends to be grade 1 asymptomatic bradycardia and something that we have to watch. General, we can also see fatigue. Unfortunately, we see fatigue across most of our oncologic compounds. And then for some, we can also see visual disturbances. So I also wanted to talk a little bit about some data that Dr. Bedard presented at San Antonio this past December from the PATA-1 trial. If you recall the PATA-1 trial, we already received some prior data, and this was kind of an update. And so PATA-1 looked at ctDNA monitoring for ESR1 mutations to inform therapy. ESR1 mutations are rare at diagnosis of metastatic disease. However, following treatment with aromatase inhibitors in the first line can be upwards of 30, even as high as 50% in some studies. And so the question was, can we prevent or delay tumor progression in patients who are receiving first-line AI plus palbociclib that have an emergence of an ESR1 mutation with a switch to fulvestrant, a different backbone, yet continuing the palbociclib as soon as these ESR1 mutations are detectable in the ctDNA. And so this was the trial schema. In step 1, again, these patients are first-line metastatic disease, hormone receptor positive, AI sensitive, and they're receiving AI with palbociclib. In step 2, if they have a rising blood-based testing of ESR1 found and no synchronous PD or progression on scans, they're then randomized to continuing their AI with the palbociclib or switching to the new backbone of fulvestrant with palbociclib. And then look at this little step 3, this optional here, because I'm going to talk about this for a second. If patients get AI palbociclib and then have progression, there's an option to then do fulvestrant with palbociclib, which gives us a little bit of information about the magnitude of benefit we're getting across first and second line to compare apples to apples. So here in PATA-1, the median follow-up in step 2 was 26 months. For those patients who remained on palbociclib with aromatase inhibitor, the median progression-free survival was 5.7 months for those patients. For those that switched to fulvestrant, it was 11.9 months. So really about a 6-month progression-free survival benefit, or said another way, really about a doubling. Now in that optional crossover cohort, so you know, the question of, well, are we just getting the PFS of fulvestrant that they would have gotten with fulvestrant if they'd switched to fulvestrant single agent in the second line setting? So this answers this a little bit. Once those patients that were on AI palbociclib and had the median progression-free survival of 5.7 months switched over to fulvestrant with palbociclib, their progression-free survival was only 3.5 months. So if you add those together, we're still getting more benefit out of that early switch than we are with waiting until progression. Now, what we don't know is, does this impact overall survival? Does this impact treatments for the future? But certainly quite interesting using blood-based detection and early switch therapy here. So phase 3 studies with a similar study design using novel SERDs are being planned in this blood-based detection of mutation space. We also saw some updated data from the BELIEVE study. if you recall, BELIEVE was looking at endocrine therapy with alpelisib in PI3 mutated, hormone receptor positive metastatic breast cancers in a post CDK4/6 setting. So if you recall in SOLAR-1, only a tiny percentage of patients had already had CDK4/6 because these trials were going on relatively simultaneously. And so the goal here was to see how is alpelisib performing post CDK4/6. And so in this cohort A, these are patients who have received CDK4/6 and AI as the immediate prior treatment, and they're coming on to receive fulvestrant with alpelisib. The median progression-free survival in the top left is 7.3 months, and the median overall survival is 26.4 months. So a little bit shorter than that 11 months that we were seeing with SOLAR-1, but certainly a benefit here of progression-free survival over 6 months. Hyperglycemia, always good to keep an idea on our adverse events and how they're trending. I think we've gotten a lot smarter in managing toxicities from alpelisib. So hyperglycemia was grade 3 or higher in 29% of patients, and grade 3 rash was 10% or higher for patients. Prophylactic use of antihistamines certainly have mitigated the incidence of rash for us, and I think we have made some strides there in making this more tolerable for our patients. So briefly before we end, I do want to touch on some novel antibody drug conjugates, because I think that in this next year, in 2022, we're going to see some of these agents for hormone receptor positive disease. This is sacituzumab govitecan, certainly a drug that we do have approval for in triple negative disease. This is a TROP2 antibody drug conjugate. In this trial for hormone receptor positive, this was a monotherapy evaluated in a single arm study. This is the tumor response to sacituzumab. You can see the red, the partial responses, the blue, stable diseases, and the kind of brown color with progression. The overall response rate was 31%, clinical benefit rate of 48%, a duration of response of over 7 months, and a progression-free survival right out about 7 months. The median number of metastatic chemotherapy lines was 2, and the prior metastatic lines were 5. Remember, these are hormone receptor positive patients, so many of them had had several lines of endocrine therapy before they went on to receive chemotherapy, had received 2 chemotherapies at least, and then were coming on study, so pretty heavily pretreated. Responses were seen in patients with prior CDK4/6. We're well familiar with this drug, that the most common adverse event now is neutropenia, and GI toxicity is also quite common. So we anticipate in 2022 to see the results of TROPiCS-02, which is the phase 3 of sacituzumab versus treatment of physician's choice chemotherapy. The accrual is completed. We're just waiting for data to mature, and we anticipate seeing the results looking at the hormone receptor positive patients to join our triple negative patients. Other ADCs that are under evaluation, and these are all deruxtecan drugs. So datopotamab deruxtecan, which is a TROP2 antibody drug conjugate in the TROPION-Breast01 phase 3. Patritumumab deruxtecan, which is a HER3 antibody drug conjugate, and trastuzumab deruxtecan for our patients that have a low HER2 expression in DESTINY-Breast06. So I anticipate more data from these compounds in 2022 as well. So a little bit about HER2 low breast cancer, certainly kind of a nomogram explaining how we get to this, but we certainly have our red box, our classically HER2 positive patients. And then over on the complete right, we have our green box, those that are IHC 0, HER2 negative. This new category of HER2 low, IHC 1+ or IHC 2+ that are FISH negative. Now, if you're IHC 2+ and FISH positive, you go into that red box for HER2 positive. So how does this orange box represent our patients? Traditionally, about 15% of our patients are classically HER2 positive, and about 30% or 40% are HER2 negative. But really the vast majority of our metastatic breast cancer patients are HER2 low, which comprise upwards of about 50% of our patients. That's even more common than triple negative. So certainly some of these patients are more classically called triple negative or more classically called hormone receptor positive, but they do have HER2 low expression. Some of the data that we've seen with TDXD or in HER2 and heavily pretreated HER2 negative metastatic breast cancer. If you look over here on the left, all patients, you can see IHCs of both 1+ and 2+, the overall response rate of about 37% and a median progression-free survival almost of a year, and then broken down by the 2+ and the 1+. Interestingly, it doesn't really seem that the 1+ do inferior to the 2+. So really suggesting that TDXD has good activity even down to low HER2 expression. And so in Destiny Breast 04, this is a trial of HER2 low breast cancer, progression on prior endocrine therapy, 1 to 2 prior lines of chemotherapy, and they're not HER2 positive, just HER2 low, randomized to either chemotherapy or to trastuzumab deruxtecan. And you can see a large choices of treatment of physician choice chemotherapy, CAPE, eribulin, vinorelbine, gem, paclitaxel, nab-paclitaxel. So very excited to see this. So I hope you have enjoyed the whirlwind tour of both hormone receptor positive as well as HER2 metastatic disease. I know that there's a separate presentation going through our improvements in triple negative, and thank you for putting up with my laryngitis and slightly a hoarse voice here. Thank you.
Thank you for giving me the opportunity to talk for OncoAlert eCancer on early hormone receptor positive and HER2 positive breast cancer. Coming on to ER positive early breast cancer, I think for both ER positive and HER2 positive, the cancers are divided into very low risk, regular risk, and high risk. So what has happened in the 2021 space is mainly for high-risk breast cancers, where we will see the data on adjuvant CDK4/6 inhibitors and duration of endocrine treatment. As far as adjuvant CDK4/6 inhibitors go, the first study was PALLAS, almost 5,700 patients. The update was presented at San Antonio, and the results were published last year as well. It randomized patients with ER-positive breast cancer to palbociclib 3 weeks on, 1 week off for 2 years, versus plus endocrine treatment versus endocrine treatment of physician choice. And the primary endpoint was invasive disease-free survival. This study included patients with low-risk cancers as well. As you can see, about 41% patients in both the arms had a low-risk cancer. And the drug was well tolerated, but if you look at the adverse events, almost 67% patients on the palbociclib arm had a grade 3 adverse event, which means more hospital visits for the patient and also has an added financial toxicity for the patient as well. The primary endpoint was not met. The 4-year invasive disease-free survival was presented. It was 84% in both the arms at a median follow-up of 31 months. If we look at the second study with the same drug, Penelope B, which was presented at ESMO last year, this is from the German breast group. Almost 1,250 patients were randomized to palbociclib for 1 year versus placebo. So there's a difference in the duration. And the primary endpoint was invasive disease-free survival. And again, they're at a median follow-up of almost 43 months. There was no difference in the primary endpoint. If we look at the quality of life, which is great that it was presented, one can see that there was a significant worsening of global health scale, physical functioning, and fatigue as far as the use of palbociclib was concerned, but it was not deemed significant by the authors. If we look at the third study, which is the Monarch E study, which is again a randomized phase 3 study with the different CDK4/6 inhibitor, abemaciclib. Patients with ER-positive breast cancer were randomized to abemaciclib for 2 years, which was continuous dosing versus endocrine treatment of physicians' choice. The key primary endpoint was invasive disease-free survival, as the earlier 2 studies with secondary endpoints stratified based on Key 67. At ASCO, the neoadjuvant chemotherapy subgroup was presented. About 2,056 patients received neoadjuvant chemotherapy in this trial. The results were published last year, and as you can see that there is a significant prolongation of invasive disease-free survival with the use of abemaciclib, and the benefit actually remains even after 2 years, if you can see with longer follow-up. And as far as Ki-67 data is concerned, you can see that Ki-67 was prognostic, but not predictive of abemaciclib benefit. Even patients with a lower Ki-67 benefited from the use of abemaciclib adjuvantly with endocrine treatment of physician's choice. The neoadjuvant chemotherapy subgroup, which was presented at ASCO last year by Miguel Martin, shows that there's an invasive disease-free survival benefit even in the NAC subgroup analysis with the use of adjuvant abemaciclib plus endocrine therapy. And the 2-year invasive disease-free survival was significantly higher, 87% versus 81% with a difference of almost 7%. If we look at the toxicities, this was presented at ESMO, the venous thromboembolism, elevated aminotransferases, and the interstitial lung disease. As you can see that all the three were higher in patients who received abemaciclib, especially the pulmonary embolism was 1%, or 27 patients had it with abemaciclib compared to 4 patients in patients who had endocrine treatment alone. And this was seen more so in those patients who actually had tamoxifen as well in the beginning. The grade 3 elevation of aminotransferases, as you can see, the blue is grade 3, is again significantly higher in patients who are on abemaciclib arm. But most of these toxicities occurred within the first 6 months of treatment. And they also looked at the Asian population and found that at least the interstitial lung disease was higher in Asian patients. Most of these toxicities were manageable, but yes, it does come at a huge financial cost to the patients. So why do we have the differences? There has been a huge debate amongst all the investigators as to why the palbociclib trials were negative and the abemaciclib trial was positive. Was it to do with the difference in the drug itself or the drug exposure? Because the drug discontinuation rates were higher in PALLAS, 42% versus 17% in Penelope B and Monarch E trial. Though the Penelope B trial, the palbociclib was given only for a year. Whether the increased duration of palbociclib in Penelope B would have made a difference, we will never know. The other thing which one has been thought about is continuous versus intermittent dosing of the two drugs. Also, whether the drug works only in high-risk patients and not in low or moderately risk patients, as the PALLAS trial had included patients with low risk as well. But I think this data are practice changing as far as the use of abemaciclib goes, though it does come with a huge cost to the patients. The adjuvant CDK4/6 inhibitor trials that are eagerly awaited are the NATALY trial, which is with ribociclib and is giving the CDK4/6 inhibitor for 3 years. Again, there is not a consensus whether we should give it for 1 year, 2 years, or 3 years. Hopefully, the studies in the future will clarify that. Coming on to the duration of adjuvant AI therapy in postmenopausal women, there are 2 studies which I will briefly discuss. This was published in New England Journal last year for patients who'd been on 5 years of endocrine treatment. Half of them were actually on tamoxifen and the rest of them on tamoxifen plus AI. 7% were only on AI. So the patients who'd been on endocrine treatment for 5 years were randomized to 2 years of anastrozole versus 5 years of anastrozole. And as you can see, there is absolutely no difference in DFS or OS with extended anastrozole therapy. In fact, the risk of bone fractures is significantly higher. So probably 7 years of endocrine treatment in postmenopausal women is enough. Looking at the Italian study, which also looked at the duration of AI therapy, this study enrolled patients who'd been on tamoxifen for 2 to 3 years and were randomized to 2 to 3 years of letrozole versus 5 years of letrozole. And again, it confirms that giving 7 years of extended endocrine treatment is enough, because patients who received 5 years of letrozole did significantly better as far as their disease-free survival was concerned compared to 2 to 3 years of letrozole. So in conclusion, the only change in ER-positive breast cancer would be the addition or consideration of abemaciclib for 2 years for patients who have a high risk based on the Monarch E criteria, and extended endocrine treatment for postmenopausal women. If they've had 7 years of AI therapy or endocrine treatment, may be enough. But this is a shared decision making that has to be done with the patient based on the individual risk criteria. Coming on to HER2 positive early breast cancer, either one wants to de-escalate in low risk or escalate in high risk. And I think this is what I'll discuss today. High risk, we know the ExtraNet and the Affinity trial were published a couple of years ago. So in low risk, whether you can reduce the chemotherapy or reduce the duration of anti-HER2 treatment. De-escalating chemotherapy 3 months instead of 6 months of chemo, the APT trial had shown fantastic results published by Dr. Tolaney, where patients received 12 weeks of paclitaxel and trastuzumab for node-negative HER2 positive early breast cancer. And this is the only phase 2 trial which has been practice-changing with fantastic results, with a 3-year recurrence-free survival of almost 99%. The attempt was an excellent attempt at de-escalating adjuvant therapy for stage 1, which was published last year. Patients were randomized to TDM1 versus the APT regimen, almost 500 patients. And one can see that the results, TDM1, the 3-year invasive disease-free survival was almost 98%. And one can say that it was not superior, but it was acceptable for patients who are concerned about neuropathy and alopecia, because with TDM1, there was less neuropathy in the trial. Though one has to say, with the biosimilars being available, the use of TDM1 will come with a huge financial toxicity to the healthcare system or to the patients. Coming on to the adjuvant trastuzumab trial, the meta-analysis has shown that there is an overall survival benefit with the use of trastuzumab for 1 year. And if one looks at all the adjuvant trastuzumab trials, so node negative and less than 1 centimeter patients were not included in these studies, though we have extrapolated the results to node negative and less than 1 centimeter patients as well. Dr. Helena Earle made a fantastic presentation at de-escalating the duration of trastuzumab by looking at individual patient data meta-analysis of all the 5 trials. And she looked at non-inferiority with various boundaries with Persephone, Fair, Hogg, Sold, and the Shorter trial. And basically, with clever analysis, she was able to show that there is non-inferiority of 6 months trastuzumab compared with 12 months, though non-inferiority of 9 weeks versus 12 months has not been confirmed. This comes with reduced cardiotoxicity, reduced financial toxicity, and reduced demands on the healthcare resources. So I think it's very important to say that we should consider the guidelines to empower our patients for personalized decision-making. Patients on single-agent trastuzumab after 6 months can be shown the evidence that continuing to 12 months provides only marginal additional benefit of 0.7%. And also it does come at the additional cost of echocardiograms and coming for the infusions as well, as the subcut version of trastuzumab is not available in most low and middle income group countries. The neoadjuvant HER2 study was quite exciting, presented at ASCO last year. This randomized patients to trastuzumab, pertuzumab versus 12 weeks of paclitaxel and dual anti-HER2 therapy, with the endpoint being pathological complete response. And as you can see, that the pathological complete response was very impressive with the triplet of almost 90%. And the patients who, the 5-year invasive disease-free survival was 98%, which is again very, very impressive. Excellent PCR rates and survival in patients treated by the de-escalated 12-week neoadjuvant weekly paclitaxel and dual anti-HER2 regimen. I think this is practice changing and will de-escalate the chemotherapy for a subgroup of our patients. Very quickly, the Impassion 050 study to show the role of immunotherapy in HER2-positive breast cancer. Almost 500 patients randomized to immunotherapy plus chemotherapy and also anti-HER2 therapy. And as you can see that patients had atezo dose dense AC versus AC, and the arm after this had atezo plus paclitaxel plus PH versus Pacli-PH for 4 cycles. Pathological complete response was the primary endpoint. Patients were stratified by PD-L1 status. And as you can see that absolutely there was no difference with intention to treat analysis for PAT-CR rate. It was almost identical. And even in PD-L1 positive, there is not much of a difference. So I think there's still a lot more work needs to be done in the immunotherapy space in HER2 positive patients with breast cancer. To conclude, I think for HER2 positive breast cancer, the de-escalation for chemotherapy and de-escalation for trastuzumab is something which we need to consider in select patients. And also patients who are T1 node negative, one can just consider the APT regimen and maybe with an abbreviated trastuzumab at 6 months as well. For T1 node positive, one can consider adjuvant chemotherapy plus dual blockade based on the affinity trial, which I've not discussed because the results were presented a couple of years ago. And neratinib, of course, can be considered in hormone receptor positive high-risk patients. To conclude, I think it's very important that these studies are crucial, but none of these studies have looked at quality of life except Penelope B, I think, which is a very important component of increasing the duration of treatment for our patients. Survival is very important because it's only 3 things that matter to our patients. Will I live longer? Will I have a good quality of life? And also the cost, especially in countries which do not have universal health coverage. So health economics has to be built in to the clinical trials when they are done. Thank you. Thank you so much.
Hello, my name is Ginny Mason, and I'm with the Inflammatory Breast Cancer Research Foundation. I've been asked by the OncoAlert team to provide a patient advocate perspective on breast cancer for 2021. I'm going to cover what I see as most impactful, what's coming in the field, and what do we want oncologists to know. Let me preface my remarks with the reminder, or perhaps disclaimer, that while I did seek input from other advocates, these are my views. Each patient or advocate will tend to see things in light of their own disease or their area of advocacy focus. My focus is inflammatory breast cancer and advanced disease. However, I do try to stay up to date on what's happening in the broader field of breast cancer. So we'll try to cover more than just my area of focus. First, most impactful. Probably the most impactful thing in 2021 for me was attending the San Antonio Breast Cancer Symposium in person. After 2 years of webinars and online meetings of one kind or another, 8 to 10 hours in front of the computer, like everyone else, it was an absolute delight to be able to be face-to-face for a change, for a meeting, to have that time with other advocates and others in the field of oncology was an absolute delight. It was probably the best thing I could do for my mental health as a patient advocate. And I was really grateful for the way people were being careful and mindful for the need of distance between people, for the wearing of masks, all of those kinds of things that made it a much more comfortable experience. And everyone at the convention center was just so glad to see us when they haven't had work for a long time. Most important to me was it was great to be back with people who understand why I do what I do. Why did I give up my good nursing job to be able to be a full-time volunteer in breast cancer? Seems like only other advocates really understand that piece. Well, on the topic of the San Antonio Breast Cancer Symposium, it is certainly impactful and exciting to see more patient advocates on the podium this year. For those of us who have been around quite a while, to be included in this program is validation that we've been heard and now have both a seat and a voice at the table. On a personal note, I learned it can also be a hot seat when it comes to questions. It required some diplomacy and quick thinking when I had my moment in the spotlight on the podium. It was encouraging to see that those patients with active brain metastases, not just being included in clinical trials, but trials specifically looking at what works in this group of patients. The Destiny trial was reported at the San Antonio Symposium, comparing trastuzumab deruxtecan versus TDM1. And it showed a subset of patients with actual intracranial responses, not just PFS. With more patients facing this devastating diagnosis, it's really essential that trials include more patients with active, not just stable brain metastasis, even if it's a small cohort. It's the only way we're going to learn and understand if these new therapies work in this population of patients. I know it's tempting to want to ignore negative and disappointing trial results, but I was really pleased to hear from the podium reports on things like the Palace trial. Yes, the results are disappointing, not what we expected, but it's also important to understand that what works well in a metastatic population may not translate to the early stage breast cancer patients. Doesn't guarantee that we'll have those same kinds of results. While there's a lot more work to be done looking at those, that study and some of the subsets, it is important to understand and to report when things don't turn out the way we anticipated. Another trial that had high hopes was the metformin and palbociclib trial, but again, didn't turn out as we expected. Publishing and presenting these data are just as important as the wins. If the community is not aware of the outcomes, we're just going to keep doing the same things over and over again and wonder why we don't get better outcomes. Another area where I'm seeing some impactful activity is in clinical trials. For far too long, we've been conducting clinical trials using the old cut and paste template documents, paying little attention to the specifics in things like the inclusion criteria. Do we really need well-managed hypertension and diabetes to be excluded? What about men in breast cancer trials? We just kind of assume it's women, right? Thanks to the combination of the pandemic and a lot of people getting on board, realizing it's time to update the clinical trial system, things are changing. More care can be provided in the patient's community or even at home. Broadening inclusion criteria gives more real-world data than we had previously available. Attention to making sure the population most affected by the disease problem are the people in the trial. That's not rocket science. We should know that. Focusing on making it easier and more affordable for patients to enroll in trials will ensure that we get better data. And in the end, we all win. Another topic that has been on the back burner far too long is diversity. It's been a big topic of conversation, but it often stopped there. It's been talk. Now we need action. Finally, we are seeing more diverse speakers for webinars, talks, panels. Organizations are examining their boards, and new groups have emerged, calling us all to be allies in moving the healthcare system to provide equitable and just care for all people, no matter their gender, skin color, language, or age. We're learning to admit our biases, our blindness, and unwillingness to budge from our comfort zones. We must continue to do better. All right, what's coming? I am excited about new options for estrogen-positive disease. For a long time, that's been an ignored area. We've tended to focus on areas of what we see as unmet need, like triple negative. The SERDs, or selective estrogen receptor degraders, are coming. Results from the EMERALD trial using elacestrant, a new SERD in estrogen-positive, HER2-negative advanced breast cancer, showed superior efficacy compared to standard of care endocrine treatment. More SERDs are in development, so stay tuned. I think we're going to be hearing more in this area. And that's exciting for those patients. That's the largest group of patients we have is estrogen-positive disease, and these late recurrences are really scary and frustrating. Continued development of antibody drug conjugates. Given the success of trastuzumab deruxtecan, we know more is going to be coming. We heard about a phase 1 study with promising overall survival using datopotamab, excuse my pronunciation, another deruxtecan conjugate. It was in a heavily pretreated group of metastatic triple-negative patients. And we all know treatment resistance continues to be an issue in all subgroups of breast cancer. Better understanding these mechanisms of resistance will be as essential as cancer continues to mutate and evade our current therapies. Another area of what's coming is clearly the use of genomics. It will need to become more widespread, particularly in metastatic disease. Access remains limited to academic centers, and we know that the majority of patients are treated in community centers. Patients willing to advocate for themselves and obtain second opinions are more likely to seek out those kinds of programs. But that's going to be challenging and expensive. Some patients are not going to be able to access them, and that's not good. We're also hearing more about the potential of liquid biopsies. I would assume most patients would prefer to have blood drawn as opposed to a surgical biopsy, wouldn't you? And we can gain some really important treatment information. That said, we want that information to be reliable and know that our treatment team has the experience necessary to use that information properly. Of course, there are more things in the pipeline. We could discuss things like immunotherapy, cardiotoxicity related to treatment, quality of life issues. Those are huge. Side effect management. We're going to find new side effects happening, and family physicians may not have an idea of what to do there. Or if we show up at the emergency room, do they know? Better diagnostics are desperately needed. Since I'm primarily in inflammatory breast cancer, we know mammograms are not the answer. And couldn't we do better? Finally, what do oncologists want? What do we want oncologists to hear? Probably first on that list is, please remember that patients are people first. We're a disease second. We're so much more than our cancer. Please take a little time to get to know us and know what's important to us. We know that your goal for treatment is to keep us alive, and we're grateful. However, patients may have a different priority or goal. Could be that quality of life is far more important than quantity of life. There may be an important life event or other motivation. Maybe they'd like to skip a treatment, delay a treatment because of a family gathering. Work with us, especially those patients with advanced disease. Please just ask us, what are our goals for the treatment? And it really would be helpful if you could provide information on how to deal with side effects ahead of time so we can be prepared. You also need to be aware that we may say we'd rather not take a treatment based on the side effects. Maybe there are other options that we would prefer. And it certainly would be helpful if you could encourage second opinions. Many patients fear rejection by their doctor if they seek a second opinion. In my experience, a doctor who doesn't want you to have a second opinion probably is not where you want to be. I'm sure you are concerned about the use of patients on the internet. We know it's a helpful and can be a detrimental tool, especially when it comes to health issues like cancer. But instead of telling patients to stay off the internet, how about guiding them to use it carefully and responsibly? Another thing is we know that each person is different and not everyone wants the same level of information or involvement in their decisions or even options. Some people are overwhelmed by all of that. We also know that makes your job harder. You have to try and figure out which one we are. But as you get to know us, that will help. You'll understand maybe the person like me who wants to know everything, and you can be ready to deal with that and my questions. And then we know there are the patients who just want you to say, this is what you're going to do, and they're happy with that. There are lots of other things I'm sure I could share, and I heard some of those from my friends. As someone who's been in advocacy for over 20 years, I've seen a lot of change in cancer care, change in patients, and in advocacy. When I was diagnosed many years ago, Metastasis meant getting your affairs in order now. And here we are. We now have metastatic organizations doing amazing advocacy work and funding research that will make a huge difference for patients. I see more and more doctors and researchers reaching out to advocates to work together, realizing that we're colleagues and that there are great things we can do together. I'm excited for what's ahead, and I'm amazingly grateful to be still here and get to watch it unfold and hopefully train the next generation of advocates. Thank you.
Hello, I'm Hope Rugo from the University of California at San Francisco's Comprehensive Cancer Center. On behalf of OncoAlert, I'm happy to present to you clinical management of advanced triple-negative breast cancer, focusing on the most recent updates from 2022. What is the optimal treatment approach for metastatic triple-negative breast cancer, and what do we know? Treatment options have changed with an improved understanding of tumor biology, and the topics that we will consider in this review are immunotherapy, where we've seen remarkable advances over the last few years, targeting defects in DNA repair, new chemotherapy options with antibody drug conjugates, where we already have one agent approved that has improved both progression-free and overall survival, and then new directions with immunotherapy combinations, new ADCs, and novel targeted therapies. This shows you the NCCN guidelines version July of 2021. These guidelines are being continuously updated, so it's better to check the website for the most current guidelines. I think what's important to see here is that there are multiple chemotherapy options, but we primarily have chemotherapy options. We now have the antibody drug conjugate, sacituzumab govitecan, and of course we have immunotherapy for a select group of patients with PD-L1 positive triple-negative breast cancer. What's important here is that these guidelines focus on non-HER2 positive breast cancer. I think over the future, this will have to change to focus on TNBC, as we are clearly treating these patients differently now than patients who have HER2 negative hormone receptor positive breast cancer, and thankfully have additional options other than sequential chemotherapy, either combined with immunotherapy, antibody drug conjugate, or with bevacizumab in patients with triple negative breast cancer in Europe. One thing that we do know, however, about triple-negative breast cancer based on several randomized trials is that maintenance chemotherapy results in improved overall survival compared to stopping chemotherapy, giving a so-called chemotherapy holiday, and then starting treatment again after progressive disease. The most recent data on this particular finding was published in 2013 based on a phase 3 study from Korea. And previously, George Sledge presented data in the past with maintenance versus observation in metastatic breast cancer. This particular trial in 2013 showed that in patients with triple-negative breast cancer, in particular, the outcome was worse when chemotherapy was stopped. And then patients only restarted treatment with evidence of progressive disease. Now, one of the biggest areas, as I mentioned earlier, for advances in the treatment of a subset of patients with metastatic triple-negative breast cancer over the last several years, and even over the last year with remarkable new data, has been with the use of immunotherapy in triple-negative disease. Impassion 130 was the first phase 3 trial to be presented. This trial randomized patients with untreated metastatic triple-negative breast cancer to receive nab-paclitaxel with either atezolizumab or placebo. Progression-free survival was improved, as you can see here, going from 5.3 to 7.5 months, a modest improvement, but statistically significant with a hazard ratio of 0.63. In addition, overall survival was also improved in the final protocol specified analysis by 7 months and with longer follow-up by 7.5 months. As you can see, the patients who did not receive a prior taxane appeared to have a better hazard ratio in the subset analysis for overall survival. So why is this these dramatic results not more impactful in terms of maintaining approval of atezolizumab in this population? 41% of patients had PD-L1 positive disease, defined using the SP142 antibody with a percent positivity of 1% or greater in immune cells alone. The trial was designed with co-primary endpoints of progression-free and overall survival in the intent to treat group, as well as the subset of patients with PD-L1 positive disease. The overall survival analysis was hierarchical, so the overall survival in the intent to treat population had to be positive to allow statistical significance of the testing of overall survival in the PD-L1 positive population. Overall survival was only beneficial in the PD-L1 positive population and not in the intent to treat population. However, given the marked difference in terms of months with a 7 to 7.5 month absolute improvement, the US FDA granted accelerated approval of atezolizumab in combination with nab-paclitaxel in patients with PD-L1 positive IC disease. Unfortunately, the accelerated approval mechanism also requires that there be a second phase 3 trial that validates these results in order to avoid chance positive finding. The next trial, the randomized phase 3 IMpassion131 trial, which I'll show you in just a moment, was not positive, did not show an improvement in either progression-free or overall survival, adding atezolizumab to paclitaxel in a similar patient population in the PD-L1 positive and in the intent to treat population. The reason for this is not clear. However, the failure of this trial, IMpassion131, to demonstrate an improvement in PFS or OS resulted in the voluntary withdrawal of atezolizumab approval in the IMpassion130 setting in the United States in the summer of this last year. Now, another phase 3 trial was done at the same time, KEYNOTE-355. This trial randomized patients who had relapsed 6 months or more after treatment with curative intent to receive pembrolizumab or placebo with a menu of chemotherapy, including nab-paclitaxel, paclitaxel, or gemcitabine and carboplatin. In contrast, IMpassion130 randomized patients at 1 year or more after treatment with curative intent, but that was the only major difference in the patient population enrolled, and I'll show you some other differences in just a moment. The first presentation of the results of KEYNOTE-355 demonstrated a statistically significant improvement in progression-free survival in the PD-L1 positive population, defined as a combined positive score of 10 or more. CPS uses a different antibody, 22C3, and a scoring system, which includes tumor cells as well as immune cells, different from the definition of PD-L1 positivity for IMpassion130. Here you can see the results in the CPS of 10 or more population with a 4.1 month absolute improvement in progression-free survival in the 38% of patients who had a positive score. It's interesting that 38% of patients were positive with a CPS of 10 or more, and 41% of patients were positive with SP142 of 1% or greater, suggesting that there may be some overlap, something we'll talk about in just a moment. Now, we saw in a press release in the summer of last year that KEYNOTE-355 had met its primary endpoint in patients who had PD-L1 positive disease, and this shows you the data presented at ESMO last year, showing the improvement in overall survival in patients with a PD-L1 CPS of 10 or more. Here you can see the absolute difference goes from 16.1 to 23 months, with an absolute difference of 6.9 months, strikingly similar to that presented with IMpassion130. This was highly statistically significant, and you can see that the landmark analyses show a marked and clinically important difference in the percent of patients surviving at both 18 and 24 months. Now, one interesting subset analysis was presented by Javier Cortez at San Antonio this last year. Here, they presented data looking at different subsets of PD-L1 positivity and the impact on progression-free and overall survival. You can see that patients who have a PD-L1 of less than 1 by CPS did not benefit from the addition of pembrolizumab, and that patients with a CPS of 10 or more, 10 to 19 or 20 or more, benefited for both overall survival and progression-free survival. However, what was particularly interesting was that there was no impact in patients who had a CPS of 1 or 9, I think validating the cutoff of a CPS of 10 or more as the way to define a patient who will benefit from pembrolizumab in the metastatic setting in combination with chemotherapy. Now, this shows you the summary of the 3 different phase 3 trials done in the metastatic setting. Impassion 130 and in Keynote 355, we've talked about in more detail. This shows you the definition of PD-L1 positivity, the percent of patients who were positive, and then the randomization and treatment. One of the important aspects is to look to see whether or not there are clinical characteristics that might have explained some of the differences that we've seen in these trials. De novo population, there were more patients with de novo disease that had not received any prior chemotherapy in Impassion 130 than in Keynote 355. Prior taxane percentages were relatively similar. The progression-free survival differences were longer in Keynote 355, a greater difference with a longer PFS in the Pembro treated group in Keynote 355, but the hazard ratios are almost identical. The survival difference in Keynote 355 was statistically significant. And although the difference in Impassion 130 was clinically important, as I mentioned earlier, it wasn't statistically significant based on the hierarchical design of the trial. Then we get to Impassion 131, which remains perplexing. The SP142 positive population was seen in 45% of the patients randomized in this trial. The randomization was a little different, 2-to-1 versus 1-to-1. The de novo population was a little lower, but similar to Keynote 355, and prior taxane use was also similar. However, there was no difference in progression-free survival in the intent to treat or PD-L1 positive population, and no benefit in overall survival. And in fact, the median overall survival in the control arm of Impassion 131 in the PD-L1 positive population was 28 months, which is longer than in any other reported trial. It's my hypothesis that it's likely that a different biologic subset of patients predominated in this trial for reasons that are not clear. Indeed, there's emerging data that suggests that ethnicity may play a role in the intrinsic subtype or biology of triple-negative disease, with more patients in the Caucasian population having basal-like disease compared to the Asian population, where there's more non-basal-like disease represented. That may explain the higher responses to capecitabine as post-neoadjuvant therapy in the Asian population than what has been observed clinically in the more Caucasian population in the US and Europe. Regardless, we will need to see additional data in order to really understand what the biologic differences are that led to negative results in Impassion 131. This lack of benefit in Impassion 131 led to the voluntary withdrawal of accelerated approval of atezolizumab in combination with nab-paclitaxel. However, atezolizumab is still approved for this purpose in other countries in the world. Now, what about safety of checkpoint inhibitors in metastatic triple-negative breast cancer? This is a very nice summary from 2019 on the toxicities commonly seen in patients receiving checkpoint inhibitors who have triple-negative breast cancer. We know that the combination of chemotherapy and a checkpoint inhibitor results in more immune toxicity than the checkpoint inhibitor as a single agent. And this data is shown here. It's really a remarkable difference. Management guidelines have been published by the ASCO, NCCN, and then there's a clinical practice guideline, which was recently published by the Society for Immunotherapy and Cancer. There's also updated ASCO guidelines that were just published in 2022 that I would encourage you to look at in terms of managing patients who were treated with checkpoint inhibitor therapy in either the early or metastatic setting. Here, I've shown you an interesting and non-clinically important toxicity from checkpoint inhibitor with the patient whose hair is growing back with this patchy hypopigmentation. She also has vitiligo. So we can see a whole host of different immune toxicities, some of which are more clinically important than others. But it's important to recognize very odd findings as being related to checkpoint inhibitor therapy, because early recognition and prompt management is essential to optimize outcomes. What are the questions for the treatment of metastatic triple-negative breast cancer with checkpoint inhibitors, as well as other subtypes? First, we don't understand why PD-L1 is important only for metastatic disease. It's an imperfect marker, but the best one we have at present. It's important to match the antibody and test to the specific checkpoint inhibitor. More data is clearly needed. One question is whether there's a best chemotherapy partner. I don't think steroids play a big role because paclitaxel was used in Keynote 355. And we talked some already about why Impassion 131 was a negative trial. We don't really know how long checkpoint inhibitors should be continued in excellent responders, but dropping chemotherapy and continuing the checkpoint inhibitor in patients who are responding is a very reasonable approach. And then we're very interested in amplifying the immune response with novel combinations in triple-negative breast cancer, extending checkpoint inhibitors to other disease subsets, such as hormone receptor-positive disease, where there are ongoing phase 3 trials, and HER2-positive disease as well. And we know that impacting DNA repair plays a role in patients who have germline mutations in BRCA1 and 2. This shows you the results from the phase 3 BRCA and Olympiad trials with talazoparib and olaparib, showing a marked and clinically important difference in progression-free survival, although in the overall populations, there was no difference in overall survival. There was a suggestion from subset analyses that if you treated patients in the first-line setting in the Olympiad trial, that there might have been an improvement in overall survival. And this makes sense because of the acquired development of resistance over the course of treatment that affects response to PARP inhibitors. Certainly, the results from the Olympiad trial in the early stage setting suggest that we may be able to overcome the rapidity of acquired resistance by treating patients earlier in the course of disease. We then saw fascinating data by Nadine Tung and consortium looking at PARP inhibitor therapy in patients who had either acquired somatic mutations in BRCA1 or 2, or different germline mutations that were associated with DNA repair. In this small trial, a benefit was seen in patients who had germline mutations in PALB2. You can see a partial response rate in 11 patients of 82%. And then in patients who had somatic mutations in BRCA1 and 2, where 50% of 16 patients had a partial response. In contrast, there were no differences in patients who had germline mutations in ATM or CHEK2, or in the 2 patients who had somatic mutations in PALB2. The responses here were quite durable, and additional patients are being enrolled in an expansion study, specifically in patients with PALB2 and somatic BRCA1 and 2 mutations. So we'll see more data on this in the future. What about antibody drug conjugates? This is a very exciting new area with the approval of sacituzumab govitecan for the treatment of patients with metastatic triple-negative breast cancer. Final approval was based on the remarkable data from the phase 3 ASCENT trial that randomized patients to receive sacituzumab govitecan or chemotherapy of physician choice. Chemotherapy of physician choice included in about 50% of patients eribulin, which has been known to improve survival in heavily pretreated metastatic breast cancer patients in both hormone receptor positive and triple negative disease. In the ASCENT trial, both progression-free and overall survival were significantly improved in patients who received sacituzumab compared to those who received chemotherapy of physician choice. Patients were eligible to enroll in ASCENT who had developed progressive disease after at least 2 lines of chemotherapy, one of which could have been given in the adjuvant or neoadjuvant setting, provided that a patient recurred within 12 months of treatment in the curative setting. Otherwise, patients who had de novo metastatic disease or had later relapses were treated after 2 lines of therapy, and there was no limit on the upper lines of therapy, remarkably. The most common toxicities from sacituzumab govitecan include neutropenia, diarrhea, nausea, alopecia, and fatigue, and many patients used growth factors about 50% compared to 23% in the treatment of physician choice arm, but there was no difference in adverse events leading to discontinuation. Subset analyses have shown that we do not need to evaluate TROP2 as an expression on the tumor cells in order to select patients for benefit from sacituzumab. Also, the benefit is seen in patients who both have germline mutations in BRCA and wild-type BRCA, and it was seen in the older population of patients with a very minimal increase in toxicity that could be easily managed and did not result in more serious toxicity. There are additional new antibody drug conjugates that are being studied for triple-negative breast cancer. Trastuzumab deruxtecan, the HER2 ADC that has been demonstrated to have a bystander effect, uses a topoisomerase inhibitor as well, a derivative of deruxtecan. In a phase 1 trial, the overall response rate in patients who were HER2 low and had triple-negative breast cancer was 14%, but in including only 7 patients. The toxicities are listed here, and I think are well known by the listeners, and will be talked about in more detail in patients treated for HER2-positive disease. Datopotamab deruxtecan is an interesting TROP2 ADC that uses deruxtecan again as the toxin, similar to TDXD, called Dato-DXd. Here in a phase 1 trial of patients with triple-negative breast cancer, a response rate was seen in 43% of patients in a phase 1b trial presented by Ian Kropp at San Antonio last year. Interestingly, they did not see pneumonitis in this small population, but more stomatitis and rash. Ladiratuzumab vedotin is a LIV1A targeted antibody drug conjugate that uses a derivative of auristatin derivative as the toxin. Here, the overall response rate is 35%, but treatment has been limited by neuropathy and neutropenia, and neuropathy being the primary limiting factor. And this drug is now being tested weekly with frequent breaks, 2 on, 1 off. And then U3-1402 is a HER3 ADC that uses deruxtecan again as a toxin and showed an overall response of 16% in patients who had HER3 high triple-negative breast cancer. Similar toxicities to trastuzumab deruxtecan, and next steps are being planned. A phase 3 trial is planned in datopotamab deruxtecan in triple-negative breast cancer. Trastuzumab deruxtecan has been studied in the HER2 low population with a limited subset that have triple-negative disease and centrally determined HER2 low disease. Accrual to that trial has been completed, and we're awaiting results, hopefully later this year. There are many trials that are evaluating combinations with these ADCs with immunotherapy, with the idea that the antibody drug conjugate will result in the revealing novel antigens and stimulate the immune response, thereby improving the response to checkpoint inhibitors, perhaps getting around the need for PD-L1 positivity or increasing PD-L1 positivity as a response by the tumor. Sacituzumab, trastuzumab deruxtecan, and ladiratuzumab vedotin are all being combined with checkpoint inhibitors in a variety of different settings, including now in the neoadjuvant setting with sacituzumab. This shows you the results of the Tropion Pan-Tumor-01 study, looking specifically at the triple-negative population. And it describes what this ADC actually is. Here's the toxin, the deruxtecan, which is a topoisomerase 1 inhibitor, the same as what's used in TDXD. The antibody is an anti-TROP2 IgG1 monoclonal antibody, and it has an antibody drug to antibody ratio of about 4, so a little lower than what we've seen with TDXD and sacituzumab govitecan, where it's more 7.5 to 8. This may actually impact the role of pneumonitis with deruxtecan ADCs, as pneumonitis was not seen in the Dato-DXd trial. There were 2 breast cancer cohorts. The hormone receptor positive population has yet to be presented. There were 30% of patients who had prior TROP1 inhibitor-based antibody drug conjugate treatment, presumably sacituzumab govitecan. And what they saw in the blinded independent central review was a response rate in the 44 patients of 34%. 15 out of 44 had a response. And you can see here's the confirmation in 14 patients. So this is an update based on the data which was initially presented, as I showed you earlier, in ESMO Breast. And then this is the subset of patients, the 27 patients who did not have prior topo-1 inhibitor-based ADC, and there the overall response rate, as you can see, was 52%, 14 out of 27 patients. That's actually very encouraging because it suggests that we could use sequential therapy in these patients to optimize treatment and help with response over time. This shows you the treatment emergent adverse events where stomatitis was seen, including patients who had grade 3 or greater stomatitis. There was also significant nausea, although most was grade 1 and 2, as you can see here, vomiting. And then diarrhea was a grade 1-2 toxicity primarily. There were no cases of adjudicated drug-related ILD, again, potentially because of the lower drug to antibody ratio, although we've seen ILD in other ADCs that have a low DAR. A phase 3 trial, as I mentioned, in TNBC is planned. Begonia is an ongoing trial in triple-negative breast cancer, evaluating efficacy and safety of Dato-DXd plus durvalumab, the checkpoint inhibitor. The hormone receptor positive cohort is fully accrued, and data is expected later this year from this same trial in hormone receptor positive disease. And then Tropion Breast 01, which is a phase 3 trial in hormone receptor positive breast cancer, has already been initiated. Now, HER2 low disease is worth a special mention here. We definitely have identified this as a subset that we're interested in based on the results from TDXD, or trastuzumab deruxtecan. This shows you the immunohistochemical picture of HER2 low versus HER2 positive and negative. And it also shows you the data in triple negative breast cancer, which I think is really important. So here, red is basal-like disease. And you can see that 2+ and 1+ is a subset of the HER2 low population, a relatively small subset. And if you look at HER2 low disease, 65% of hormone receptor positive breast cancer is HER2 low, and only 37% of patients with triple negative breast cancer. However, if you think about 37%, it's about the number of patients who are eligible for checkpoint inhibitor therapy. So it's clearly an important subset. The DAISY trial actually looked at TDXD, and this data was presented at San Antonio this year by Veronique Dieras. And what you can see is here's cohort 2 with the HER2 low expressing population. And what you can see is triple negative breast cancer. Here they've get the best overall responses in the entire population at 37.5%. But here you can see it broken down into triple negative breast cancer. There were 15 patients. The response rate was 40%. The PFS was short at 3.5 months, but still this is quite encouraging. And these were reasonably heavily pretreated patients. Here's the group who were HER2 0 in triple negative breast cancer. The response rate was again 42%, 5 out of 12 patients, but the progression-free survival was only 2.1 months. The duration of response was longer though, and I think this is an interesting cohort to look at in the future, despite the fact that the PFS here was relatively low and the absolute numbers were not met to declare success. The toxicity is important. They had 5 patients that discontinued for ILD. We're learning how to manage ILD better now. The majority of ILD was grade 1 and grade 2, and there were no drug-related deaths. There are a number of ongoing phase 3 trial of antibody drug conjugates in HER2 low breast cancer shown here, Destiny Breast 04 that we discussed, Destiny Breast 06, which is another trial looking at patients who have HER2 negative or low disease. And this will give us a little bit more data about what happens in patients who have HER2 negative disease. And this treatment is given in the first line setting, which I think will be helpful in patients who have triple negative, who have a hormone receptor positive disease, who may not have the same degree of toxicity and may not have the risk of ILD. And then here's a trial with a newer ADC. We didn't talk about disitamab vedotin versus treatment of physician choice in patients who have 1 to 2 prior lines of therapy, prior anthracycline therapy. And these patients can either have triple negative or hormone receptor positive disease. So where we're going to get results in the triple negative population is the Destiny Breast 04 population and this disitamab vedotin trial, which is ongoing. This trial, Destiny Breast 06, will give us more information about the IHC 0 population and greater than 0, less than 1, but a hormone receptor positive in the first line setting. Now, there are a number of studies looking at trying to amplify the immune response. The phase 2 Nimbus trial was presented at San Antonio. Very interesting data I'll show you in just a moment. There are a number of different trials looking at combining checkpoint inhibitors with antibody drug conjugates, and I've shown you several of the schema for these trials, as well as results from an induction study called the TONIC trial, which is now being studied in a phase 2 setting. There are checkpoint inhibitors being combined with PARP inhibitors, as well as radiation therapy. This is the data I promised to show you from the Nimbus trial, an exploratory phase 2 study looking at the combination of nivolumab and ipilimumab in patients who had HER2 negative metastatic breast cancer with a tumor mutational burden of 9 or greater. There were only 9 patients who had triple negative breast cancer. It turns out this high tumor mutation burden is much more common in patients who have hormone receptor positive lobular cancer, pleomorphic lobular cancer, but there are some patients with triple negative breast cancer. 13% were PD-L1 positive. And you can see here the median duration of response in responding patients was 12.1 months. You can see that 17% of patients had a partial response. The clinical benefit rate is cut off, but this was seen also in 5 patients. They looked at the subset of patients who had a high tumor mutation burden because of this very short progression-free survival. And what you can see is that in patients who had a high tumor mutational burden, although it's a very small number, the overall response rate was much higher, and the progression-free survival was 9.5 months. So this high tumor mutational burden of 14 or greater clearly predicts for a greater response to checkpoint inhibitor therapy. The combination did result in more immune toxicity. 30% had at least grade 2 or greater immune-related adverse events. Lastly, let's talk about the SUMMIT trial briefly. This is a subset of the SUMMIT trial that had triple-negative breast cancer. More patients had hormone receptor positive breast cancer, where we've seen more somatic mutations in HER2. There were 18 patients who had triple-negative breast cancer who qualified for this trial. 3 had lobular histology, where we've seen more somatic BRCA mutations and perhaps lost their ER. The median number of prior anti-cancer regimens was 3, ranging from 1 to 7%. The objective response rate was 33%, quite striking, and the median duration of response wasn't valuable as yet. But you can see the responses here, as well as other mutations seen in those in that population of patients that didn't seem to affect response, because a lot of patients had loss of TP53, and many patients had PIK3CA mutations. It may be that some of these patients were hormone receptor positive and lost receptor positivity over time. The median PFS in this population was 6.2 months, which is quite impressive, and then brings this up as a potential treatment for patients with triple negative disease and a HER2 somatic mutations with neratinib and trastuzumab. There is ongoing interest in trying to treat patients based on intrinsic subtyping using gene expression profiling, using this particular profiling approach with 4 different subtypes based on intrinsic or expression profiling. You can see the different definitions here, and then a plan in the future trials based out of Shanghai from Shao et al., looking at treating patients based on their intrinsic subtype. This is a very interesting area, which is ongoing, treating patients with different treatments based on how their gene expression profiling suggests their disease is driven biologically, and we'll see what that shows us over time. So we've seen progress in triple-negative breast cancer. There's a defined role in triple-negative breast cancer using immunotherapy with chemotherapy, and in metastatic patients, PD-L1 positive disease. We have a lot more work to do amplifying the immune response. There's expanding use of antibody drug conjugates for triple-negative breast cancer with sacituzumab established, and many others along the way. And then we'll see where we go to in terms of trying to treat patients earlier, an area we couldn't talk about, thinking about whether or not we could identify patients earlier who will develop triple-negative breast cancer and start treatment earlier. And there's great interest in using drugs like sacituzumab as well as checkpoint inhibitors in patients who have cell-free DNA in the clinical trial setting. After neoadjuvant therapy, those who have high risk with residual disease, in trying to either delay or prevent the development of metastatic disease. I'll leave you with a roadmap for metastatic triple-negative breast cancer, patients who are PD-L1 positive, treated with checkpoint inhibitor upfront, and subsequently can receive PARP inhibitors if they have BRCA mutations. The choice of chemotherapy would depend on the timing from adjuvant treatment. Patients who have PD-L1 disease still receive chemotherapy in the first-line setting or a PARP inhibitor if they have a germline mutation. This would be followed by sacituzumab govitecan. And then, of course, in patients who had high tumor mutational burden, checkpoint inhibitors can be used either as single agents or in combination with chemotherapy. There are many clinical trials that are being evaluated now. Atezolizumab can be used outside of the United States where approval is maintained. For HER2 or BRCA somatic mutations, I would consider targeted therapy based on the data we have to date, understanding that these are small trials and still exploratory. And it's important to consider clinical trials at each decision point. Thank you so much for your attention.
Hi, my name is Sara Tolaney. I'm a breast medical oncologist at Dana Farber Cancer Institute, and today I'm going to be discussing treatment of early-stage triple-negative breast cancer. As I think many of us all know, triple-negative breast cancer has been associated with shorter overall survival compared with other subtypes of breast cancer, despite therapy with both anthracycline and taxane-based treatment. Here you can see outcomes for triple-negative breast cancer, both in the early stage and late stage setting, again suggesting the worst outcomes from the triple-negative subtype relative to other subtypes of breast cancer. Because of these poor outcomes, there have been many attempts to try to improve outcomes by adding additional therapy to the anthracycline and taxane backbone. Some of these strategies that we'll discuss today include adding platinum-based chemotherapy or adding immunotherapy, and then also thinking about adding additional therapies sequentially after anthracycline and taxane treatment, particularly in those patients at very high risk of recurrence. For example, those patients with residual disease, where we'll discuss the addition of capecitabine or PARP inhibition in patients with germline BRCA mutant disease. So starting with the first strategy of trying to add platinum therapy to improve outcomes. We've seen several neoadjuvant trials which have attempted to add platinum to chemotherapy in order to improve rates of pathologic complete response. Generally, these studies have suggested that adding platinum does improve PCR. The challenge, however, has been whether or not, in truth, this addition is in fact extending long-term outcomes. And data that we have had to date has been conflicting with regards to its ability to improve event-free survival. Here we see outcomes from the GEPAR-6 study, which had added platinum to an anthracycline and taxane chemotherapy backbone, suggesting that the addition of platinum did improve event-free survival. However, CLGB-40603, which had also looked at the addition of platinum to anthracycline and taxane, in fact showed no difference in terms of event-free survival. These studies, however, were preoperative trials that were not adequately powered for event-free survival and has made it challenging to understand what, in fact, the improvement would truly be. We've now seen a third preoperative trial report event-free survival, and this is the Brightness study. This study had, in fact, looked at adding veliparib to chemotherapy and, in fact, found no benefit to the addition of veliparib to the platinum taxane backbone. However, when they looked overall in those patients who had received platinum as well as taxane and anthracycline therapy, they found that the addition of platinum did improve event-free survival with a hazard ratio of 0.57. So this, again, is more consistent with the data we saw from GEPAR-6, but in opposition to what we've seen from CLGB-40603. So I think what we can summarize is that what we know is platinum does improve PCR fairly consistently. There is no smaller benefit seen in those patients who have germline mutant BRCA disease, since these patients seem to be highly chemosensitive in general. However, we also know that adding platinum improves rates of breast conservation when done in the preoperative setting and can decrease the extent of axillary surgery. It does, however, increase toxicity, and we saw this with more dose holds and dose reductions needed in those patients getting ACT chemotherapy. And in fact, from the CLGB-40603 study, saw that in fact, in some patients where it led to decreased taxane exposure, in fact, it may actually hurt outcomes because you're omitting standard therapy by decreasing exposure to the taxane. So I think we have to be cautious when thinking about the platinum due to potential toxicity risks. But overall, I think it does suggest, particularly with the Brightness study, that it may be, in fact, improving event-free survival and could be something considered in our high-risk patients. Another strategy that has been considered is adding immunotherapy to chemotherapy. And the rationale for this has really been that adding immunotherapy can lead to increased PD-L1 expression. We can also see that chemotherapy will lead to more tumor lysis, more antigen presentation, and therefore potential more synergy. And so in the setting of chemo potentially also inducing PD-L1 expression, these agents can be synergistic. And so there were some early studies that had suggesting adding immunotherapy to chemotherapy may in fact improve PCR rates. And then we saw a large registration study looking to see if adding immunotherapy to chemotherapy in the preoperative setting would not only improve PCR, but could potentially improve EFS. And so the Keynote 522 study was designed for patients who had stage 2 and 3 triple-negative breast cancer, and patients all received anthracycline, taxane, and platinum backbone chemotherapy with or without pembrolizumab in the preoperative setting. And then after surgery, for those patients who received pembrolizumab, they went on to get 9 additional cycles of pembro as opposed to the control arm, which continued on placebo. These patients did not receive adaptive therapy in the post-pre-op setting based on response to treatment. What we saw was that adding pembrolizumab to chemotherapy did in fact improve rates of pathologic complete response. This was true at the time of the final analysis for PCR, as well as when they looked at all patients, all 1,100 patients in the trial, where they also continued to see a statistically significant improvement in PCR. You can, however, see that the delta between the two arms for PCR did go down by the time they did their first interim analysis to their third and final analysis of PCR. This, however, seems to be more due to the fact that the control arm seems to be performing better with each subsequent interim, whereas the experimental arm with pembro remains fairly consistent with around the 63-ish% PCR rate. One thing that was quite interesting, however, was that PD-L1 did not predict benefit to pembrolizumab. So here you can see that the PD-L1 negative patients, in fact, had a larger delta between the two arms relative to the PD-L1 positive patients. But what we do see is that in general, PD-L1 positive patients tend to have higher PCRs in both arms relative to PD-L1 negative patients. What was particularly important, however, was now with long-term follow-up with the fourth interim analysis, adding pembrolizumab to chemotherapy did lead to improvement in event-free survival that was statistically significant, with a hazard ratio of 0.63 and an improvement in IDFS from 76% to about 85% at the 36-month mark. We've now also seen updated subgroup analyses that suggest that this benefit is not just restricted to the very high-risk patients, so those patients with node-positive disease, but also is seen in those patients even with node-negative disease, with in fact very similar hazard ratios between the node-positive and node-negative patients, which is quite interesting and I think a bit unexpected, particularly since we saw much larger deltas in terms of PCR in the node-positive population. And so while we're seeing very impressive improvements in not only PCR, but importantly EFS, we have to weigh these benefits against potential toxicity. And what we do see is that toxicity seems to be higher, particularly in the combined phase of therapy, so in that preoperative portion where they're getting both chemo and pembro, compared to the adjuvant portion of therapy where you see treatment-related AEs are much lower, suggesting that much of the immune-related toxicity is occurring early in the preoperative phase, with lower rates of immune-related toxicity occurring in that adjuvant phase. And so while I think these data are practice-changing and really suggest that we should be integrating immunotherapy with chemotherapy in all of our early-stage triple-negative patients with stage 2-3 disease, I think it leaves us still with many questions. When we think about the preoperative phase, I think we need to think about, do we really need to be giving anthracycline, taxane, and platinum chemotherapy? Is there an ideal chemo backbone? And could one even see benefits with less chemotherapy in future studies? Additionally, I think we need to understand, are there some patients that aren't going to benefit from immunotherapy? Because now we don't have a biomarker predictor. We saw that PD-L1 was not, in fact, a predictor for benefit. And this is challenging because we are exposing patients to toxicity, and ideally we would want to be able to identify those patients that are going to derive benefit, whereas now it is really just all-comer stage 2 and 3 patients based on the data that we have. And then in the adjuvant portion of therapy, the way treatment was given is not quite the way we would traditionally think of treating patients in the modern era, where we are adapting therapy based on response to pre-op treatment. Here, all patients who had received pre-op pembro got adjuvant pembro. And are these patients actually deriving benefit from that adjuvant portion of therapy, or was the amount of immunotherapy that they received concurrently with chemotherapy enough to drive that EFS benefit? This trial did not test whether or not the adjuvant portion was adding or not, since all patients received it. And so we don't really know that from this trial, and I think further work will be needed to address this question. And I also think we are curious to know what to do with our residual disease patients, since we know that these patients are at high risk of recurrence. Should we be adding additional therapy, as we have often done prior to these data being available? So starting off with one of the first questions is, what is the optimal chemotherapy backbone? Certainly Keynote-522 used all anthracycline, taxane, and platinum backbones, but it has made us wonder, is there one particular type of chemotherapy that will act better and more synergistically with immunotherapy? There's some suggestion from this very innovative study, the TONIC trial that was done in the metastatic setting, where they gave patients induction of various types of chemotherapy or even radiation prior to use of immunotherapy. And here you can see that the activity seems to be greatest in those patients receiving anthracycline therapy, with a close second being platinum, but less so with cyclophosphamide. And so here this would suggest that maybe patients should ideally be getting anthracyclines because, again, it seems to act very synergistically with therapy. We have some data to suggest that this may be true, because in the NEO-TRIP study, which had omitted anthracyclines in the pre-op phase and had just given taxane platinum therapy with or without atezolizumab, we saw no difference in terms of PCR rates, suggesting that with a non-anthracycline backbone, we are not improving PCR, and so maybe that anthracycline is needed. In truth, we have not yet seen, however, the event-free survival data from this trial, which will be important to really definitively conclude what the appropriate treatment is, since all these patients did get adjuvant anthracycline treatment. And we know that PCR may not be the best indicator of response to immunotherapy, where longer-term outcomes may be more relevant here. And so I think, again, it will be important to see EFS, but for now, I think these data suggest that perhaps anthracycline is a critical component of our preoperative treatment given concurrently with immunotherapy. Here you can see results across several different immunotherapy trials, and you can see in all the other studies that did use anthracycline-based therapy, such as the I-SPY study, as well as IMpassion031 and JEPAR-Nuevo, that all of these studies did at least lead to a numerically improved PCR rate from adding immunotherapy to chemotherapy, although JEPAR-Nuevo was not statistically significant. So what about the adjuvant portion of checkpoint inhibition? Is that really needed? Here we can see that the patients who achieved PCR in Keynote-522 did very well in both arms of the trial. So in the 522 Pembro arm, you can see for patients who achieved PCR, the event-free survival was almost 95%, and it was about 93% in the control arm, again suggesting that patients who achieve PCR do well. Whereas the patients who had residual disease, so below the patients who had no PCR, you can see much poorer outcomes with much lower EFS rates, but again, dramatic improvement here for the EFS for the residual disease patients from the addition of pembrolizumab. The JEPAR-Nuevo study, I think, is informative, even though it was a small randomized phase 2 trial, because it used anthracycline and taxane therapy in the pre-op setting with or without durvalumab, but did not give any adjuvant immunotherapy. And despite the lack of adjuvant portion of the checkpoint inhibition, you are seeing remarkably similar benefits in terms of IDFS and and distant disease-free survival, as we've seen in Keynote-522. And I think this has made many of us wonder, is that adjuvant portion really needed? Because here it wasn't given, and we're seeing very similar long-term outcomes. Here we also see that those patients who achieve PCR do exceptionally well with treatment with pembrolizumab. So here you see 95% 3-year outcomes with the patients who achieved PCR, whereas those patients who had residual disease, again, much poorer, so very consistent with Keynote-522. But because here we're really not able to address the question of if adjuvant immunotherapy is adding. And because there's some suggestion from Jepar Nuevo that maybe you don't need the adjuvant immunotherapy because people are doing well without it, I do think a study is needed to help address this. And so the cooperative groups have been thinking about how to design this, and the Alliance group has decided to move forward with a study called Optimized PCR, which will help address this very question. So it will take patients who received preoperative chemotherapy with pembrolizumab and achieved PCR, and then randomize them to get that 9 cycles of adjuvant pembrolizumab, so that 27 weeks of exposure, or allow them to just get observation. And this will look at, in a non-inferiority design, at long-term outcomes to see if, in fact, there is any difference between the two arms. If, again, it seems that observation is similar to pembrolizumab in terms of EFS, it would suggest that use of pembrolizumab in the adjuvant setting for the PCR patients is not needed. So I think, again, for now, pembrolizumab is the standard of care in the adjuvant setting, irrespective of response to pre-op therapy. However, we do need more work to see if this is really necessary, particularly in the PCR patients. So what about the opposite group, the patients who have residual disease? What do we do here? I think prior to Keynote 522 being available, most of us have been giving capecitabine. This is really due to data that we've had from CREATE-X that had taken patients who had residual disease and randomized them to receive 8 cycles of capecitabine or no further therapy, and found that in the triple-negative subgroup of this trial, there was a statistically significant improvement in disease-free and overall survival from the use of adjuvant capecitabine. That being said, I think, overall these data still suggest outcomes are poor, with about a 70% 5-year IDFS, even when patients had received capecitabine. We also saw data from the ECOG trial that had taken residual disease patients with triple-negative breast cancer. They actually had to have at least a centimeter of residual disease, and then they looked at PAM50 subtype and randomized the basal-like patients to receive platinum chemotherapy or capecitabine. And I think this study was a bit disappointing because it showed really there was no difference between adjuvant capecitabine and platinum. But I think even more importantly, it showed that outcomes are very poor in these patients who have basal-like triple-negative disease with a centimeter of residual disease, with IDFS rates of around 50%. And so I think, again, this suggests that these patients need more because capecitabine alone, while it has been shown to add benefit, is still not making patients have good outcomes. It's just improving it a bit from the poor outcomes that we've previously seen. And so now with the introduction of immunotherapy, it begs the question, should we be adding capecitabine to that adjuvant portion of pembrolizumab? And certainly here we do not have data to know what the added benefit would be. We do have data from the metastatic setting that has looked at this combination. This was a trial that looked at capecitabine and pembrolizumab for metastatic triple-negative disease in both the first and second line setting, and showed that it is a tolerable regimen. In fact, also showed very nice activity in this setting. And so I think, there is safety data to suggest we can give it concurrently with pembrolizumab. And so I think it is reasonable to consider in our high-risk patients because we have been looking to do more for this population. What about, however, our germline BRCA mutant patients? We have data now from the Olympia study that had looked at the use of olaparib for a year in patients with high-risk disease. For triple-negative patients, this could be patients who had residual disease or patients who went straight to surgery and at least had T2N0 disease or greater. And they got, again, a year of olaparib or placebo, and these patients all had to have germline BRCA mutant disease. Here we saw that there was about a 40% reduction in IDFS events from the use of adjuvant olaparib and a numerical trend even at this early time point for overall survival. And so I think these data do suggest that adjuvant olaparib should be standard in our germline BRCA mutant patients. However, what does that mean in the era of immunotherapy? What do we do with the patient who has residual triple-negative disease who's received preoperative immunotherapy? Do we give the olaparib with pembrolizumab? There's some suggestion that PARP can act synergistically with immunotherapy, with the idea being that use of PARP inhibition can augment STING activity, which can lead to synergistic activity with checkpoint. And in fact, we do have some trials that have looked at the combination of PARP with checkpoint in the metastatic setting. However, I think these data have been hard to interpret because, for example, the study of olaparib and durvalumab, the Mediola trial, showed a PFS that was very similar to what we've seen for PARP monotherapy, and in fact showed an OS that was also quite similar and not different by PD-L1 status. And so I think the challenge is that we don't have randomized data of PARP plus or minus checkpoint, even in the metastatic setting, to know for sure that adding checkpoint is beneficial. There is an ongoing study in the metastatic setting of olaparib with or without atezolizumab that will help address this. But we do have safety data from both the Tepacho and Mediola studies for combination therapy, and there's some preclinical rationale to suggest that there may be synergy. And so because of this, and because we know in Olympia, PARP inhibition is important for our high-risk triple-negative patients with germline BRCA mutant disease, and because adjuvant pembro is standard in someone who's had pre-op immunotherapy, I think it is reasonable to consider use of olaparib with pembrolizumab in your residual disease patients who have a germline BRCA mutation. And so here's just a little schematic of how we could consider approaching our triple-negative breast cancer patients with stage 2-3 disease. I think given 522, the standard is to use platinum anthracycline taxane chemotherapy with pembrolizumab. If patients have residual disease, I am generally offering capecitabine with pembrolizumab if they're BRCA wild type, or olaparib with pembrolizumab if they're germline BRCA mutant. For those patients who achieve PCR, the standard would be to give the 9 cycles of adjuvant pembrolizumab. But as you can see, I think, again, we need to better address this adjuvant portion of therapy because what is shown here is not truly very data-driven. We don't actually have data for what the outcomes are for Cape Pembro or olaparib Pembro, and I think we need to figure out what the optimal regimen would be. So where may we be headed? We've seen that outcomes with adjuvant capecitabine are not great in the residual disease population and definitely makes us want to do better. And so can we think about novel strategies in this space? One such study that is doing this is the SASIA trial, which is led by the GBG and is taking patients who have residual disease after preoperative therapy and randomizing them to sacituzumab of treatment or treatment of choice. Here, majority would be capecitabine. The challenge with this trial, though, is it was initiated prior to immunotherapy being standard of care, so many patients will not have had immunotherapy in the pre-op setting, and they are therefore also not getting immunotherapy in the adjuvant setting. Additionally, this trial combines both ER-positive and triple-negative patients into one study, making it challenging to potentially interpret the EFS data that will emerge from this trial. So I think it will be an interesting study that will help us better understand the utility of sacituzumab in the residual disease setting, but won't optimally address this question of how to handle patients post-pre-op immunotherapy. I think another challenge that we have is what do we do about the use of adjuvant immunotherapy in someone who hasn't had any immunotherapy in the pre-op setting. So there are trials that were conducted to look at immunotherapy in patients who had residual disease but didn't get any pre-op IO. And so, for example, the SWOG study took patients who had received pre-op chemo, had residual disease, and randomized them to get pembrolizumab or observation. Patients were allowed to have received capecitabine in the adjuvant setting prior to going on to this trial, so they could have gotten sequential capecitabine pembro for the study per physician's choice. The ABRAVE study similarly was looking at avelumab in high-risk triple-negative patients, either those with high-risk adjuvant disease or residual disease after pre-op therapy. But again, these trials were for patients who hadn't had preoperative immunotherapy. And so it won't help us understand what the utility is of adjuvant immunotherapy in the high-risk residual disease patient. And so I think we're going to need to think about this more about how to address our residual disease patients after checkpoint inhibition. Since capecitabine, again, hasn't had terrific outcomes for these high-risk patients, I think we do all want to think about other strategies. And so could we think of a trial that takes a residual disease patient and gives them adjuvant antibody drug conjugate therapy, such as something like sacituzumab or Dato-DXd? Or could we have another arm that then combines the ADC with pembrolizumab, and then have a third arm as our control, which would be pembrolizumab with potentially the allowance of capecitabine to be added to it? And so this way you could sequentially look to see if the ADC pembro performs better than the pembro capecitabine, and if so, you could compare the ADC to the pembro capecitabine arm, really helping you address this question about whether or not the adjuvant pembrolizumab is adding in the adjuvant setting, and if we can do better than capecitabine pembro by using a novel strategy like an ADC. So again, I think we need to move towards these types of designs because we need to do better for our residual disease triple negative patients, even in the era of immunotherapy. So thank you so much for your attention. I really appreciate it. And certainly if you have any questions, you can always address me on Twitter at stolaney1. Thank you so much.
Dear colleagues, it's a great pleasure and honor for me to be part of the 2021 OncoAlert Colloquium. My name is Matteo Lambertini. I'm a medical oncologist and adjunct professor in medical oncology at the San Martino Hospital, University of Genova, in the northwest of Italy. Today, it's a pleasure to discuss a topic in which I'm particularly interested in, which is fertility preservation in breast cancer patients. After a brief introduction, I'm going to address the three main available strategies for fertility preservation in these patients, then the issue of pregnancy after breast cancer, so in women that completed treatment for breast cancer, before final conclusions. The reason why we are discussing this topic is because it is of high value for many young women with newly diagnosed breast cancer. This is a statement made by young women advocates strongly suggesting the importance to address these issues, and its fertility and pregnancy-related issues are indeed one of the top 3 priorities for young women with breast cancer, a field where our young women advocates ask us more research effort in the field. However, we are going to discuss not only fertility preservation, because the toxicity of chemotherapy, of anti-cancer treatment on gonadal function is not only infertility, but it's a more general concept of premature ovarian insufficiency, meaning infertility, the impossibility to have a pregnancy following treatment completion, but this means also a lot of other side effects of early menopause that can have a major negative impact on the quality of life of our patients. Anxiety, depression, sexual dysfunction, and behavioral issues. So it's important to discuss not only fertility preservation, but a more general concept of ovarian function and fertility preservation. This is a prospective study we are conducting in my country, trying to address what are the needs of young women with breast cancer in terms of the available strategies for fertility and ovarian function preservation. And what we observe is that if we look at the patient under the age of 40, so those women that we normally refer to fertility units for fertility preservation strategies, around 20% of them are interested in fertility preservation strategies, in cryopreservation options. But even a higher percentage, more than 90% of these patients, are interested in receiving ovarian suppression during chemotherapy as a strategy to reduce the risk of early menopause, suggesting the importance, of course, to discuss fertility preservation, but a more general concept of treatment-induced gonotoxicity and the issue of premature ovarian insufficiency. If we do not discuss these survivorship issues, may have a negative impact on the survival outcomes of our patients. So can have a survival impact, negative impact, because we know from many studies, including a recent publication from the Canto investigators, showing that if we do not address this topic at the time of diagnosis, but also during treatment and during patient follow-up, many women may decide to receive less effective but less gonodotoxic treatment, or may decide to stop the proposed treatment before standard duration, like stopping endocrine therapy before standard duration of 5 or 10 years. So what are the available strategies for fertility preservation? Before going into that, two important statements by the newly updated ESMO guidelines on this topic. First statement, discussing the risk of premature ovarian insufficiency should be done with all patients diagnosed during the reproductive age as early as possible in the treatment planning process, so as soon as possible after diagnosis, irrespective of type and stage of the disease. Also, women with advanced breast cancer should be informed about the side effect as we inform them about the other side effect of anti-cancer treatment. Second important statement, that we should consider every patient receiving an anti-cancer treatment at potential risk of gonotoxicity. This risk, we are going to see, it's different based on the treatment, on the age of the patient and other factors, but all patients, even those that are very young, receiving treatment with a low risk of gonotoxicity, may have a potential risk of gonotoxicity. The two key factors to discuss the risk of gonotoxicity are the age of the patient at the time of diagnosis and the type of treatment, and specifically chemotherapy, they are going to receive. The older the age of the patient, the closer to the natural age of menopause, the higher the risk of treatment-induced gonotoxicity. The use of alkylating agents such as cyclophosphamide are associated with the highest risk of gonotoxicity. So the first step of the oncofertility counseling is to discuss the risk of that specific patient receiving that specific treatment to develop this side effect. And as you can see from this table, the same treatment like anthracycline taxane-based chemotherapy in patients older than 40 years at the time of treatment have a high risk of gonotoxicity. More than 80% of these patients will develop premature ovarian insufficiency. But if we look at the same treatment in patients under the age of 30 years, we see that the risk is very low, below the threshold of 20%. Another potential factors that can be associated with an increased risk of treatment-induced gonotoxicity is the presence of a pathogenic variants in the BRCA genes. This is still debated, but there's a growing amount of evidence suggesting that the presence of a pathogenic variant in BRCA genes may be associated with a reduced ovarian reserve even before starting anti-cancer therapies. And so this is of concern that giving anti-cancer treatment to this patient may further increase the risk of gonotoxicity. It is not proven yet. There are small and conflicting data on this regard, but we have to keep in mind that we are currently escalating the treatment of this patient, like addition of carboplatin as neoadjuvant chemotherapy on the top of anthracycline, cyclophosphamide, and taxane-based chemotherapy. We are very soon adding olaparib for a year, following completion of chemotherapy. So we really need to address the risk of treatment-induced gonotoxicity in BRCA-mutated patients. Moving now to the second step of the oncofertility counseling. So first, informing the patient about the side effects. Second, offering the available strategies to counteract this side effect. The first standard option of fertility preservation is embryo or oocyte cryopreservation. This is a surgical option that requires around 10-15 days of hormonal manipulation called controlled ovarian stimulation. After these 10-15 days, the oocytes can be collected and then directly cryopreserved for oocyte cryopreservation or fertilized before cryopreservation for embryo cryopreservation. With this technique, we don't have a 100% success rate. The success is strongly dependent by the age of the patient at the time of the procedure, with a pregnancy rate of around 40%, above 40% in patients that are very young, below the age of 35 years. And this pregnancy rate is going to decrease significantly in patients older than 40, with less than 10% pregnancy rates in this setting. And so normally we do not suggest fertility preservation option and embryo oocyte cryopreservation in patients older than 40, 41, 42 years of age. In terms of safety concern, we are giving hormones for 10-15 days to patients just diagnosed with breast cancer. So this has been a concern for many years to many oncologists. However, we have now several studies, most of them retrospective, single-center studies, but still several of them suggesting the same conclusion, that giving these few days of hormonal manipulation before giving chemotherapy afterwards does not seem to increase the risk of recurrence in breast cancer patients. And this is also the case for patients with hormone receptor positive disease, even if the data are even more limited in this subgroup of patients. In breast cancer patients, particularly those with hormone receptor positive disease, we suggest to include letrozole as part of the protocol for control ovarian stimulation, because including letrozole does not worsen the performance of the stimulation. So the number of oocytes that are collected after the stimulation with or without letrozole is actually the same. However, giving letrozole decreases significantly the estradiol level in the blood of the patient during the 2 weeks of hormonal manipulation, and this can be of importance for breast cancer patients. Second option is ovarian tissue cryopreservation. This is considered now a standard option in patients that are not eligible for oocyte or embryo cryopreservation. These are more complex surgical techniques that require 2 surgical procedures. The first one to remove ovarian tissue fragments, usually from both ovaries. These fragments are removed before chemotherapy, cryopreserved, and then transplanted back to the patient, usually in an orthotopic site, so in the pelvis or directly in the ovaries, following treatment completion. In terms of pregnancy rate, it's close to what we have just seen with oocyte or embryo cryopreservation. However, there are 2 important considerations for the success of this procedure. First, this is effective only in very young women, patients under the age of 35, 36 years. There is no pregnancy described in cancer patients above the age of 36. Second important consideration is that the success is strongly dependent by the expertise of the center doing the cryopreservation procedure. And so what the guidelines suggest is to set up a so-called hub and spoke model so that different oncology units will refer patients interested in this procedure to a more experienced centralized fertility unit. The surgical procedure, so the removal of ovarian tissue fragment, can be done in peripheral centers, but the cryopreservation procedure should be centralized in experienced center. So the tissue can be removed in one center and then sent a few hours away to another more experienced fertility unit. In terms of safety concern, 2 important considerations. The first one, not really that important for breast cancer patients, but for women with other diseases, is the risk of malignant contamination of the ovarian tissue fragments. This is of particular concern for hematological malignancies and ovarian cancer. For breast cancer patients, the most important safety concern is the presence of a germline pathogenic variants in genes associated with a high risk of ovarian cancer, like BRCA1 and 2. Cryopreserving a tissue that should be removed at a young age because of this high risk of ovarian cancer is not, of course, the optimal strategy. However, we have reported a large series of BRCA-mutated breast cancer patients that received this procedure at a very young age, so several years before the recommended age of risk-reducing surgery, and this procedure can be considered safe with some special consideration, especially in the transplantation procedure. Finally, the use of ovarian suppression with pharmacological ovarian suppression with GnRH agonists during chemotherapy. This is important to highlight that it's not a fertility preservation option, but it's more an option to protect ovarian function during chemotherapy, so an option to reduce the risk of premature ovarian insufficiency. It's still a bit debated how this strategy works, so what's the mechanism of action of this option. The most important hypothesis is that it decreases the production of FSH, and so the ovaries are put in a sort of dormant state during chemotherapy so that they are less sensitive to the gonotoxicity of chemotherapy. Even if the mechanism of action is still a bit debated, the clinical data, especially in the breast cancer setting, are now very solid to support the use of this option as a standard procedure for ovarian function preservation. Again, it's not an option for fertility preservation, not an alternative to cryopreservation procedure for fertility preservation. If we give GnRH agonists during chemotherapy as compared to chemotherapy alone, we reduce by around 15% the absolute rate of premature ovarian insufficiency following chemotherapy. with more than 60% reduced risk of developing the side effect when a GnRH agonist is given during chemotherapy. And there is also some signals that can be also considered a fertility preservation strategy, with a significantly higher number of pregnancies in the GnRH agonist group as compared to the control group observed in randomized trials. However, the numbers remain small, and again, this option has not been studied and should not be considered as an alternative to cryopreservation option for fertility preservation. In terms of safety consideration, in the past, there were some concern that giving hormones during chemotherapy could be detrimental on the efficacy of chemotherapy. This is the case, it's true for tamoxifen. We have preclinical and clinical data suggesting that tamoxifen should not be given during chemotherapy. However, there is no preclinical nor clinical data supporting the same concern for GnRH agonists. We have data from a large individual patient level meta-analysis of 5 randomized trials and also from the soft and text trials, suggesting that giving GnRH agonists during chemotherapy or following chemotherapy completion is actually the same, so does not really worsen the prognosis of our patients. So it's safe to be given also in women with hormone receptor positive disease. Finally, on the topic of pregnancy after breast cancer, I wanted to briefly touch on these regards, because still breast cancer survivors are among cancer survivors those with the lowest chances of having a future pregnancy following treatment completion. Cancer patients in general have lower chances of pregnancy as compared to the general population of a similar age, but breast cancer patients are those with the lowest likelihood of future pregnancy, together with cervical cancer survivors. One important explanation is what we have just discussed: risk of treatment-induced gonotoxicity, lack of access to fertility preservation strategies. However, in breast cancer patients, there's an additional important concern, which is the risk of recurrence for pregnancy after breast cancer, and the concern by many physicians that this is the case. This is a survey among breast cancer physicians that we have launched a few years ago, and among the question that we asked, we wanted to see what the physician believed regarding the safety of pregnancy after breast cancer. And as you can see, around 30%, so 1 out of 3 responding physicians was not sure that pregnancy is safe. And this percentage went up to almost 45%, so almost 1 out of 2 responding physicians that was not sure that pregnancy is safe in BRCA breast cancer survivors. However, the data we have, mostly retrospective, but also large, well-conducted studies, do not support this concern, and they strongly suggest that pregnancy after breast cancer, of course after adequate treatment and follow-up, should be considered safe, is not detrimental for the prognosis of our patient, does not worsen disease-free survival nor overall survival. This is also the case in patients with hormone receptor positive breast cancer. No difference in DFS nor in OS between those with a pregnancy following treatment completion as compared to patients without a subsequent pregnancy, and with a trend for a better prognosis for patients with hormone receptor negative disease and a subsequent pregnancy. Also, in the specific cohort of BRCA mutated patients, we have now a large study suggesting the safety of pregnancy following treatment completion for breast cancer, with a trend for better disease-free survival for patients with a subsequent pregnancy and no difference in overall survival. We have still one important question in this field to be answered, which is the safety of stopping endocrine therapy before the standard duration of 5 years to allow women to have a pregnancy, so to have a break in the endocrine treatment during the first 5 years, to then resume endocrine therapy following pregnancy completion, following delivery. This is a question that is being answered by the positive trial that enrolled more than 500 patients with hormone receptor positive breast cancer that received between 18 to 30 months of endocrine therapy and were allowed to stop endocrine treatment for up to 2 years. And we will probably have the results in 2022. Finally, the safety of pregnancy on the baby side. We have seen that there is no increased risk of the majority of potential complications for pregnancies in breast cancer survivors as compared to the pregnancies in healthy women from the general population. Particularly, there is no increased risk of congenital abnormalities in these pregnancies. What we have observed is a higher risk of cesarean section, low birth weight, preterm birth, small for gestational age, so some pregnancy complication that for which we should consider these pregnancies as a high-risk pregnancy, so should be monitored as, more closely as compared to what we do in healthy women from the general population. So in my conclusion, 2 slides. The first one is how to perform an oncofertility counseling in young women with breast cancer. First, discussing the risk of gonotoxicity, so the risk of treatment-induced premature ovarian insufficiency. For patients that are interested in preserving fertility, so that are interested in a potential pregnancy following treatment completion, the first option to be discussed are cryopreservation strategies, with embryo and dorsal cryopreservation to be preferred in patients that have at least 2 weeks available before starting anti-cancer therapies, and ovarian tissue cryopreservation to be used in patients that do not have these 2 weeks available. After cryopreservation option can be discussed the use of GnRH agonists during chemotherapy. On the other side, we can have patients that are not interested in fertility preservation, so they have already completed their family planning, they are not really interested in a pregnancy following treatment completion, but they don't want to enter menopause at an early age, so they are concerned about the risk of premature ovarian insufficiency. In this case, GnRH agonist during chemotherapy is a standard option to be offered to this patient. Final point, we have also to discuss contraception with our young women with breast cancer during treatment, but also during the follow-up, because we have data in the literature suggesting that many pregnancies, spontaneous pregnancies in breast cancer survivors are observed in women that did not really want to have a pregnancy and did not proactively attempt to have a pregnancy. Final conclusion, and probably the most important one to this, for this presentation, to have a good care of our young patient in terms of oncofertility management is really highly important to have a strong network with the fertility unit and to build the so-called oncofertility unit within the same hospital of the oncology center, or also a connection with the fertility unit outside our oncology center. This connection is really important, not only at the time of diagnosis to offer the strategies for fertility preservation, but it's also very important during treatment, and particularly during the follow-up of our patient, like those patients receiving adjuvant endocrine therapy, to discuss other gynecological related issues that are really important to our patient. I've already mentioned contraception, but also, for example, sexual dysfunction because of the use of ovarian suppression as part of adjuvant endocrine therapy. So the oncofertility unit, the network with the gynecologist, is highly relevant, not only for fertility preservation strategies, but also for a more general gynecological care of our young women with breast cancer. And with that, I really wish to thank you for your attention.
Dear friends, welcome to the Colloquium 2021 by OncoAlert. And let's see what the 2021 have for radiation therapy and early breast cancer. I'm Icro Meattini from University of Florence. I have no conflict of interest to declare concerning this presentation. This is my outline, policy and editorials, reviews, guidelines, and clinical trials from the last years. Among policy and editorials, I suggest you to see the EBCC 12 manifesto. As you know, in Europe, inappropriate reimbursement and funding rules and regulation sometimes act as disincentives to best breast cancer care. And then, unfortunately, reimbursement policy have rarely evolved with advances in breast cancer and a lot of several tasks, such as the use of hyperfractionation in breast radiation therapy. Let's read this really interesting paper led by Fatima Cardoso, Philip Pormans, and colleagues about the importance of having reimbursements that better align with guidelines, and optimal clinical practice will certainly deliver more cost-effective healthcare, and will release resources and support more equity in use of funding and limited resources, so allowing breast cancer patients to benefit from evidence-based treatment. Again, in March 2021 has been published the ESTRO core curriculum clinical oncology module to be joined to the 4th edition of ESTRO curriculum, and the aim was to develop a clinical oncology module that could be combined with the ESTRO curriculum to enable clinical oncology trainees to follow a single curriculum. The module consists of more than 20 enabling competencies in the medical expert role that are required to be added to the ESTRO curriculum for the training of clinical oncologists. The clinical oncology module, when combined with ESTRO curriculum, covers the entire cancer pathway rather than being just a modality specific tool. And this is hoped to be the development of comparable standards of training in clinical oncology across Europe, and may probably have utility in low and middle income countries. Again, Reshma Jaxi promote this really amazing perspective published in the New England Journal of Medicine, where it's really important aim, the growing evidence that pandemic associated disruptions have had a disproportionate effect on women's personal and professional lives. We know that there's a gender-based difference currently, independently of the pandemic effect, related to the academic physicians dedicated to parenting, caregiving responsibilities. These existed before the pandemic, and pandemic-associated disruption may have exacerbated the social isolation, particularly in fields in which women are underrepresented. The main question is if we will, in academic medicine, and not only academic medicine, intentionally choose the right question to seize this disruptive opportunity and to harness this moment to accelerate positive change toward gender equity and inclusion in medicine. Have a nice reading of this important piece of paper. Again, being published by the Fast Forward team, these nice editorials and policy paper on the Fast Forward trial reported on the 26 and 27 grind 5 fractions scheduled over 1 week versus 40 gray in 15 fractions over 3 weeks. As we know, the trial reported at 5 years follow-up, non-inferiority in terms of local control, with no difference in the main subgroup analysis in terms of local control, but also in terms of normal tissue effect, where there is a low absolute rate of moderate MET, NTE, and mostly moderate, not severe change. And also in this case, independently of age, breast size, surgical deficit, tumor bed boost, or adjuvant chemotherapy prescription. So the discussion is just open, but this is a new effective standard of care for whole breast irradiation. And again, Erika Hamilton and the team from the ESTRO breast courses published on September on the Green Journal, Tricks and Tips for Target Volume Definition and Delineation Breast Cancer, Lessons Learned from ESTRO breast courses. This is a really nice lecture on the importance of adopting volume-based treatment planning for non-metastatic breast cancer that has increased greatly, along with the use of improved planning techniques essential for modern therapy. And this is really important for from a practical oncology point of view. Concerning reviews, 2021 was a rich year. I was honored to lead with Philip Pormans and Lorenzo Levin and other excellent experts in breast cancer this narrative review published on the JAMA Oncology in Jan 2021 on the association of breast cancer radiation with cardiac toxic effects. We know very well the importance of promptly recognize and manage cardiovascular risk factors before, during, and after cancer treatments. decreasing the risk of cancer therapy-related cardiac dysfunction. And the heart disease risk seems to be higher in patients with tumors sited in the left breast, when other classic cardiovascular risk factors are present, and when chemotherapy, mainly anthracycline-based, is prescribed, suggesting a synergistic association with radiation therapy. Main focus on available drugs and respiratory control, as well as modern radiotherapy techniques, as reported in this review. And again, in September 2021, we published a nice critical review of breast reconstruction and radiation therapy, together with an Italian expert Delphi consensus statements, thanks to the friends of the Italian Association of Radiation Oncology and the Breast Reconstruction Greta Association. It's really nice to see the importance of combination and timing of radiation therapy of breast reconstruction, that it's really an open question. The paper is based on a Delphi consensus statement after a critical review led by this core group of professional profiles involved in management of breast cancer, with a final consensus of 26 key statements on radiation therapy and breast reconstruction. One of the crucial conclusions is based on the importance of communication between clinical radiation oncologist and breast surgeon, both in the setting of breast reconstruction following mastectomy, when post-mastectomy radiation therapy is planned, but also when an extensive glandular oncoplastic breast conserving surgery is performed, highlighting the importance of a shared decision-making relying on an outcome-based and patient-centered consideration while waiting for high level of evidence data. Another really interesting review is on the importance of the bolus use that we know overcome the skin sparing effect on external beam radiation therapy, ensuring an adequate dose to superficial regions at risk of local or regional relapse. This is a systematic review led by Anna Dawn and Orit Kaider-Persson, and this systematic review summarize the current evidence regarding the impact of bolus on local relapse and acute toxicity in the setting of post-mastectomy radiation therapy. 27 studies included, with the evidence of a higher rate of acute grade 3 radiation dermatitis and pooled crude local relapse rates similar between groups, with main conclusions based on the bolus indicated in patients selected with high risk of local relapse in the skin, not necessary for all patients. The question is still open. And again, Ella Senkus and Philip Portmans, together with me and other professionals on breast cancer, we had fun at the end of the year publishing the de-escalation of axillary irradiation for early breast cancer. This is really important, highlighting for patients at low risk of distant relapse, a reduction in systemic therapy use combined with an optimal local regional RED that could be a new approach. Although extreme caution should be taken when decide to omit one or the other therapeutic approach, they really suggests to conduct the de-escalation optimization process in a stepwise manner, carefully monitoring the potential increase of local regional relapse and not only rates, therefore suggesting enrollment of patients preferably in prospective controlled randomized trials, or where it's not feasible, into high quality and reliable registries of data. And then again, guidelines from 2021, another important point this year of pandemic, Peter Dubsky and colleagues led this amazing toolbox of breast conservation axillary management after primary systemic therapy with early breast cancer, the Lucerne toolbox, related to the increasing use of primary systemic therapy in the treatment of patients also affected by early breast cancer, where few guidelines exist. This is an international consortium that developed clinical guidance recommendations that we use we hope to convince clinicians and patients of the major clinical advancement led by primary systemic therapy with the use of less extensive and more targeted surgery, and not only to improve the lives of patients treated with excellent breast cancer therapies. Erika Hamilton, Birgit Offersen, and colleagues from the Icro Committee then published in January 2021 the evaluation of acro delineation recommendation for immediate breast reconstruction, analyzing several plans with distinct technique, field and field, VMAT, AMAT, combined tomotherapy and hybrid techniques, and this is a very nice paper, really practical, where this evidences the difference between radiotherapy techniques could be used to plan radiation therapy in the setting of immediate breast reconstruction, where it's clear that the best distribution results as a balance between the objective target volumes and high dose organs at risk, and how this radiotherapy technique affects the interplay between these objectives. Have a nice reading. Gustavo Marta from Brazil and other colleagues from the Breast International Group then published this international consortium report on the financial impact of reimbursement of moderate hyperfractionation on postoperative radiation therapy for breast cancer. As we know, unfortunately, reimbursement varies depending on countries, cities, private or public framework. We obtained and collected data from 13 countries for all the world, where the most of countries receive a remuneration based on number of fractions rather than technique. Although this generalized adoption of moderate hyperfractionation breast radiotherapy would allow for a considerable reduction in social and economic burden, this kind of financial loss induce a slow uptake of these regimens on current clinical practice. So we suggest an alternative system of remuneration, such as bundle payments based on stage and diagnosis, that might hopefully provide more value for all stakeholders. And Erika Hamilton, Birgit Offersen, and the Breast Cancer European Group published the Delphi study international consensus recommendation on the use of bolus after the critical review that I previously presented in the setting of also use of bolus in the setting of post-mastectomy radiation therapy. So the discussion is still open. The main findings are related to the use of 3-5 millimeters of daily bolus for chest wall, indicating highly selected cases where the skin is deemed to be within the clinical target volume. Moreover, a custom bolus to a limited area or risk can be considered to reduce unnecessary toxicity and achieve better dose distribution. And the community of breast cancer environments should commit themselves to validate the use of this and other consensus by reporting morbidities and recurrence pattern in all patients treating according to reliable rules. And at the end of the year, we published the European Society for Radiation Therapy and Oncology Advisory Committee in Radiation Oncology Practice Consensus on patient selection and dose and fractionation for external beam radiation therapy in early breast cancer. This was really a near work with these amazing colleagues that led us to a new consensus of partial breast irradiation patient selection for external beam radiation therapy, and really important concerning the equity of access for all patients to receive an evidence-based breast external beam radiation therapy to help to translate to new evidence into routine daily practice. Main findings and related to moderate hyperfractionation radiation therapy as can be offered to any patient for whole breast, chest wall with or without reconstruction, and nodal irradiation volumes, and the ultra hyperfractionation 5 fraction as fast forward can also be offered for non-nodal breast or chest wall without reconstruction radiation therapy either as standard of care or within a randomized trial or prospective cohort. And finally, clinical trials this year. Don't forget the Europa trial. That's a trial on de-escalation of treatment in patients aged more than 70 years old affected by T1 and 0 early breast cancer, luminal A-like tumor T1 and 0 randomized to receive exclusive radiation therapy or exclusive endocrine therapy. This trial is based with the main objective to determine the patient-reported outcomes in terms of quality of life and non-inferiority in terms of local control in this de-escalation, or rather better defined, optimization trial with local control and quality of life as primary endpoints. And the Elliot trial has been published at a longer follow-up phase 3 trial comparing intraoperative electron radiation therapy, partial breast and whole breast irradiation that confirm a significant difference between arms in favor of the whole breast irradiation. We know very well that this was due to a bad selection of patients with high-risk features rather than a technical point of view, but this difference has been maintained over time. The difference at 10-year rate was 8% as compared to 12% in the Elliott group, and whole breast irradiation, the 10-year is 1% as compared to 2.4%. So long-term, the results for this intraoperative radiation therapy partial breast trial confirm the higher rate of ipsilateral breast tumor recurrence in the partial breast irradiation intraoperative arm. And this trial was published in July 2021 concerning the DCIS and the use of trastuzumab together with radiation therapy in HER2-positive patients at 80 months median follow-up. These studies did not reach the predefined protocol-specified events, so the definitive analysis was triggered by all patients having been on study for 5 years, and the addition of trastuzumab to radiation therapy did not achieve this objective of 36% reduction in local relapse rate. So this trial currently had negative results. Philip Pormans and the OTC radiation oncology and breast cancer groups reported about the side effects of 15 years after lymph node irradiation in breast cancer from the EORTC 22-922 trials of internal mammary node radiation therapy. At 15 years median follow-up, the cumulative incidence rates demonstrate a significant higher percentage of lung fibrosis and any cardiac disease in patients treated with the internal mammary node, but no difference was observed in the incidence of second malignancies, contralateral breast cancer, or cardiovascular deaths, highlighting the importance of patient selections for this regional node irradiation extensive treatment. And McCormick and colleagues, led by Julia White, reported on the NRG-RTOG 9804 trials, the only randomized trial to assess the impact of whole breast irradiation versus observation in women with good risk DCIS cancer following lumpectomy. The 14 years median follow-up confirmed that the 15-year cumulative incidence was better for patients receiving radiation therapy, even if affected by good risk DCS features, 7% with radiation as compared to 15% in the observation arms at 15 years. Also concerning the invasive local relapse, 6% as compared to almost 10% in the observation arms. So radiation therapy significantly reduced all an invasive ipsilateral breast recurrence for good risk DCS with over time at 15 years. And with this, I would like to thank again the OncoAlert family for the invitation. I hope that you enjoy this year in review, and I welcome to the 2022 exciting years. I hope there's a successful and healthy year. Thank you very much.
Thank you all for joining us for this day 3 and a warm invitation to join us tomorrow for day 4 of this colloquium, when we will be discussing the year in review for GI oncology and the EON session with an amazing faculty. Reminding you that this colloquium video is now available at our YouTube channel on demand and will be available from now on. These will also be available next week through the European School of Oncology and eCancer through their websites. From all of us at OncoAlert, thank you once again for joining us and look forward to seeing you all tomorrow.